public service announcement. If there's ever an issue with anything, especially prior filler, more filler is not the answer. A lot of times when someone comes and says they don't want to look funny like so-and-so, they're attributing something to surgery that's actually from filler. It is filler. It's not surgery that made them that way. There's a lot of filler in there. When I go in sometimes and I touch an area with filler, it literally jets out at me.
Ew.
Filler seems like this panacea of an entry point to aging, right? You just put in this magical gel and it makes you look great and it goes away in a year or two. And that was the belief, especially a decade plus ago. And over the last decade, we've really started realizing a lot of things about fillers that need to be updated.
What's good about talking to you is I've learned so much. What's bad is... Hi, I'm Gabby Reece. I'm a retired professional volleyball player and a co-founder of XPT Fitness and Layered Superfoods. On this podcast, we interview experts about the latest in health and fitness so you can maximize performance in all areas of your busy life. Today, I'm talking with the leading facial plastic surgeon, Dr. Cameron Chesnut, and he has worked with top performers all across the world. As you'll hear in this conversation, I've never personally had work done. Well, you can probably see that. Listen, not only am I curious, but with rates for plastic surgery skyrocketing over the past 10 years and the industry turning into a $70 billion market, I wanted to see what I was missing. So whether you're considering plastic surgery or completely against it, there is a lot to learn within this conversation. Welcome to the Gabby Reece Show. Let's go. Dr. Cameron Chesnut, welcome to the show.
Thank you for having me.
And I already know a lot about you without knowing you because you just went through pool training.
Yes, right. That was fun. That was a unique experience for sure.
Yeah, but you killed it. And the thing is that for me, and given your occupation, I think it's so important to know how somebody acts when there's stress.
Oh, right. Very much so.
Yeah. So why don't you share a little bit about what your type, people love titles.
Yeah, right.
Just so they know. And what I'm curious about too is, do you only do facial plastic surgery?
Right. Yeah. Yes, I do. So I am a facial plastic surgeon, which means I work sort of collarbones up. That's my wheelhouse that I operate in. And I practice up in the Pacific Northwest, and I have a travel-based practice, meaning I kind of have my little shop set up there. It's like a little retreat, very wellness and regeneratively focused, and my patients travel to see me and get their procedures done. And I approach their procedures kind of from the mindset of an athlete, really, which I think you and Laird really relate to. I know I do, and the way that I prepare and execute their surgeries and then recover afterwards, and the way that I get my patients ready to come and get through the process. And then even bigger deal for them is that recovery part of it. That's where the professional athlete thing really comes in now. It's a little bit of a different mindset. And so it's this wonderful relationship that I get to create where I find people who really resonate on the same level, and we create this kind of lifetime bond and do some really fun and cool things, really.
Yeah, you do a lot of beautiful work. I obviously getting ready for this, so I'm going to put you on the spot for a minute.
All right.
And it's not the bad spot, but so I'm 54,
mm-hmm.
and you probably can tell I've not had any.
Right.
You said that quickly. Do you see that?
No.
Clearly you haven't had work done.
I mean that in a very positive way.
I'm teasing. Yeah. I'm totally teasing. So if I came to you, health wasn't an issue, mm-hmm. finances weren't an issue, I won't get offended. Okay? But just to give people a sense of what's out there. What if I came to you and said, do what you would do if I was like your sister?
Ooh, yeah.
Go ahead.
So first of all, you are my demographic, basically. High achieving, high performing, baseline beautiful, care about your health, haven't done much. That's like the normal situation. I do a fair amount of revision work. So people who kind of got into trouble, not even trouble. Sometimes it's just suboptimal. They got a 7 out of 10 and they know that it could be better type of thing. But I mean, my first instinct is to seek to understand better, because there isn't a one size fits all approach. There isn't like, oh, what would you do, magic wand? Like, my question for you is, well, if you had a magic wand, what would you do?
Oh, so you put it back on the patient.
To some degree, because I need to understand where your value system lies. And because we're always walking this balance. Like, my secret sauce a little bit is trying to apply the Pareto principle to our procedure. I want to know what 20% input can we get to get 80% of the results. But that carries a huge value for you. That's where this relationship part comes in. It's not about me creating the same thing for everybody that walks out. You see that, and in my opinion, the wrong way to go about it. And I think that happens more as people lose a little bit of dynamism, and I want to keep that alive. And I want you to, everybody that comes to me generally is saying, I want to look how I feel. And that's unique, I think, to my patient demographic a little bit. And I want to give them that. So, okay, what are we shooting for? What's our metric of success? Before we start climbing a ladder, we want to know that ladder is leading to where we want to be ultimately when we get to the top a little bit.
Don't most patients have unrealistic expectations? Don't they come in, and how do you manage that? And we'll get back to you skirting around what you would do to my face in a second.
Okay, that's fair. That was a little bit of a skirting answer.
It's cute.
Yeah, the unrealistic expectations, I find that sometimes, but it's rarely, I should say, I don't like to say never, but it's rarely in sort of a malicious way. It's generally just a lack of knowledge or understanding about what's possible, what's needed. Some people are heavily researched, and I like that, actually. I like it when people have been following along with me for a year or 2 years or 10 years, whatever it's been. And then they kind of know when they come, like, okay, you're the right person for me. I like your philosophy. I like what you do. I like how you prepare. I like your mindset. That's my dream, right? I don't want somebody who comes to me saying, I want a facelift. Then it takes a lot of work for me to get through. Like, well, let's understand what you really want and need. And you think that it's maybe a facelift, but I want it to be like, we want each other, basically, and let's find that magic recipe between us that's going to get us to where you want to be from a just satisfaction, happiness, whatever you want to call it.
Do you say no?
All the time.
Why? Yeah. What are the reasons that you would say no?
That's a very good and loaded question.
Well, I'm a smoker and I'm a drinker, and I think I'm like, are there no's like that?
Yeah, if somebody is actively smoking, it's a no-go from the start, and that doesn't click with me as well anyway, because I love the John Wooden idea of like, make each day your masterpiece. I quite literally approach what I do that way, and it's yours when we're done, but I don't want you to ruin it either. I want it to be something that you value as well. And so if somebody does smoke in that rare circumstance, generally this is their opportunity to quit, which gets really into a lot of my life, which is when you come to me, I want you to leave better on all fronts of your life for you. I want your health to be more optimized. I want you to understand what's happening even on a genetic level better with you. And sometimes it's even musculoskeletal things. I work with a regenerative medicine doctor in my practice who might take care of your achy knee or spine, this is the time to do it when we're together and recovering, and you're doing all these modalities that we'll talk more about later. They're multifaceted. They help all of those things quite a bit. So back to
let's say I'm a smoker, and you say, okay, I'll give you've got to quit for
4 weeks,
a month before, and then you can't smoke
ever.
Right. But if we lived in reality, let's say, and you certain people, they're just like, what would be the drop dead, like after?
That's another 4 weeks afterwards.
Okay.
And that's based off of sort of how our wounds heal and like an inflammatory profile. I want that to be super optimized for that period of time afterwards. Ideally, it's even 8 or 12 weeks if we're really getting into it. Yeah. But 4 weeks is like an absolute destruction time frame if you're smoking early in that.
Is that oxygen, a lack of, and that's really what's not helping the healing process?
Yeah.
And obviously there's chemicals in there that create an inflammatory response.
Yeah, that's a multifaceted issue as well with inflammation, right? There's the reason that the 4 week is the number is because in that first 4 weeks we go through like this wound healing process where we have an inflammatory phase and we have a proliferative phase, and we're creating new blood vessels, quite literally angioneogenesis, making new blood vessels. And that's heavily damaged with smoking and inhibits that. And we need those blood vessels to feed the fat transfer that we did or help the tissues secure together after we very deftly move them together. So we don't want to disrupt that. That's actually the same reasons for like when we time exercise and getting blood pressure up and shear forces. It's all based around these little blood vessels forming. So smoking will just destroy that amongst other inflammatory things or excessive movement or elevated blood pressure, whatever it is.
Okay, so let's get back to me now.
Yeah.
Because I'm just going to be your crash test dummy. So you were here at my house, pool training, the masks. Because I think about this. I'm going to be totally honest. I don't mess around with my face. But there's a part of me that I go, hey, listen, if it's going to fall-ish, gravity, I would get one and done. That's what I said. A lift everything, kind of give it a yank in the best possible way, and be done with it. Because I sort of go, I'll do everything I can do that's in my power to stay vibrant and vital. Looking that I don't need to look 20. That's obviously not going to happen. But then I start going, well, you're out in the sun. Oh, you wear the mask. Like just to pool train, thinking about that mask.
Right.
So would that be something that you'd be like, oh, you can't do that anymore?
No, absolutely not. I mean, this is where we get into, you've got to live life afterwards. I want you to go into the world, your best self, and be happy and perform and do all the things you want to do. Even if wearing a mask afterwards does have some small decrease in our results, that's what we're forging you for. We want you to be strong going into it. So that's not an issue. Because a lot of what you mentioned are qualitative things, right? You're in the sun, you're putting a mask on your face. How miserable would your life be if you weren't wearing a mask and in the sun?
Yeah.
So I'm not about that at all. I want to, this is seeking to understand you a little bit too. Okay. What are our metrics of success? What's it going to be like for you afterwards? What are the things we're targeting? To really get to your question, honestly, is okay, you're like that quintessential on the fence of what do we want to do? How invasive do you want to be? Here's our options, because there should be a conversation about multiple types of lifting as we're getting into that. There's a bunch of different ways you can approach that. There's ways that are completely invisible, scarless, awesome, incisions hidden back in the temple that are a couple of centimeters long. And you can get durable, realistic lifts out of those, but it's not maybe as robust as a more traditional approach to a facelift that we could do. And so it's like, well, do we want to have incisions in front of your ears, or do we want to avoid those and take the route that's the 80-20 rule maybe, and get an appreciable amount of lift? Is that enough for you to cross this arbitrary threshold of being satisfied or happy? And there's a weighing of the input and the output when we're doing that. So there's a lot of conversation back and forth, and you are honestly in the most challenging spot for that. You are, because it's what do we want to do? How minimally invasive do we want to be versus measuring against realistic expectations for results?
This podcast is brought to you by Bond Charge. I was fortunate enough, I got their red light face mask a few months ago. Anytime I share something with you, I like to use something for a while before I talk about it. And right away, one of the things I love about the red light face mask, so simple to use. It's cordless, it's soft, it fits my face so easily. So it's just 10 minutes a day, so I can be doing other things, other tasks at my desk, and voila, there it is. And the other thing is red light face mask, it really penetrates deep into the skin. It boosts collagen production, it reduces inflammation, just kind of eases those signs of aging. So if you've been thinking about it, it's like having a mini spa at home. You can start adding Bond Charge's red light face mask to your daily routine too. All you have to do is order one today. Right now, my listeners will get 15% off when you order from bondcharge.com and use my exclusive promo code Gabby, Gabby, at checkout. This discount, it applies site-wide. They also have other great products if you want to check them out. But if you've been curious about the red light face mask, now is the time. That's bondcharge.com. And you'll also get free shipping and a 12-month warranty. Really important. So that's bondcharge.com, BONCHARGE.com. And don't forget to use the promo code Gabby to get 15% off. Yeah, and I know that's the constant. Even I think sometimes these little beauty tweaks that people do, they think somehow it's really going to make an impact. And really what you realize is it's hard to fight time. And so when you have someone who comes to you and you get a sense of, I don't want to say it's a mental wellness illness issue, because I have other friends that are plastic surgeons, and they literally will say when it becomes kind of a mental illness, an obsession, every little place. What do you probably know it right away.
Right. That's my job at this point, is to understand that. Because then I'm contributing to negative mental health for that person if I don't understand that. And that's a trap I think that younger surgeons or younger providers will fall into early on, because they're just seeking repetitions, and that person will let that happen.
Yeah.
But those tend to be challenging situations to manage afterwards. And so that's part of me understanding, like, I do not operate on anybody that I don't know fairly well, honestly. And that's where some of the no's come in, is just I'm kind of, doing that person a favor in some sense of, not supporting that or not going down that road, or you kind of don't need that. It's not my job to tell them that they don't need it, but when things seem, it's called dysmorphia.
Yeah,
like not looking at yourself in the form that you are, not seeing the form that you really are. I have to recognize that and kind of go through it a little bit.
Do you ever say, hey, maybe you could go talk to somebody? Yeah, or is that getting a little
That gets a little, it probably depends on where we're at in the process, So if we're further into it and I'm starting to realize that that's maybe a healthy person or a healthy thing for that person, that's certainly a conversation that I'm not afraid to have. It's a challenging, difficult conversation, but it's opportunities for growth for both of us too in that. Mm-hmm. But early on, a lot of times I'm just understanding and screening away from that in the first place, so that I don't even lead the person down the path necessarily. So
you do more traditional style lifts where there's incisions, mm-hmm. and then you do ones where it is scarless or you can't see it. Are you doing equal amounts?
Yeah.
Are you doing more of one than the other?
It's really individualized, and over time it's definitely gravitated towards more of the less invasive. So when you say I do normal lifts and things like that, to be fully honest, every procedure I do to some degree is innovative, progressive, a little bit different, trying to take advantage of those, Pareto principles and understanding what's really changed. And we were talking about this offline earlier, a little bit about just keeping harmony in what's happening. So when somebody's coming in, I'm almost never, I don't like to say never, but almost never doing one procedure, because nobody is only aged in one place, right? So it's finding the small degrees that person may have had all over and keeping things united. Sometimes it's a brow, an upper lid, a lower lid, a cheek, a jawline, whatever it is. Great. If you can get a little improvement in all those areas, that adds up to a great whole that is more stealth, maybe more challenging to understand what happened. And that's what I want when this is my calling card.
What's going on? Did you get a haircut?
Right.
Yeah.
That's my, when you look at my before and after photos, that's my goal. And I'd encourage you to go onto my social media and take a look at that. Anybody who's listening, and you'll just see, it's like, this person looks better, but I can't exactly figure out what they had done or happened. That's my win when I can accomplish that. But the secret to that is doing little things that are adjacent to one another. Then my job is to understand where the low-hanging fruit is, where the impact happens, how to mix qualitative and quantitative things together. We talked about qualitative things with your skin. Well, that's an important part, because no surgery is ever going to improve the quality of the soft tissues. That's where regeneration comes in. Regenerative medicine with stem cells, with fat transfer, with lasers, things like that. Those are wildly important parts to, number one, the outcome, and number two, the long-term durability of what we're doing. So those are staples for my, sort of recipes that I'm putting together.
You mentioned in your practice you have other doctors. Do you have other plastic surgeons in your? Because I was thinking, what if somebody comes in and goes, and while I'm at it, I want to do my boobs and this and that, and it's just you're doing the face.
Yeah, I sort of focus on, like I said, collarbones up, neck, face, and those other providers are regenerative medicine, so like heavy stem cell based things. So that gets into in my recovery, I don't like using anti-inflammatories, because that inflammation is one of our phases of wound healing that's really important. I would rather modulate and optimize that inflammation, which is what stem cells are built to do, and they gravitate towards that. So that would be like one of the other providers that you might work with, and that provider might also, like I said, take care of some osteoarthritis issues or other inflammatory or autoimmune types of things. And then I have a functional medicine provider that I work with as well, who really helps me in our nutritional profiles after, nutrigenomics after, even designing my preoperative protocol and diet that I put my patients on. I was a nutrition major as an undergraduate in college, and so was this functional medicine provider. And so we just love to nerd out a little bit on how nutrition can make things better.
So first of all, what's the decision for collarbones up? Like when did that happen? And
I'm a dive deep kind of guy in general. Whether it's a rabbit hole or a subspecialty of medicine, I like to have this very deep dive into what I'm doing, and I'm very much a subspecialist in that. So I like to do the procedures that I do and do them very well. But I find that interestingly, as you dive into those deep holes, things get more complex, and I start to find new avenues to create sort of new innovations within that. And so it never really feels like a narrow space. It actually starts feeling wider as I get deeper into it a little bit.
Yeah, well, and it's hard. I have another friend who said they won't do any rhinoplasty.
And I'm one of those people.
You are too?
Correct.
Because people are never happy, right? Well, that was what he oversimplified it, but he was like, it's the least sort of satisfying for the patient. They sort of never, he found, so he's like, I just stay out of it.
And I think that a lot of that is, I think there's two reasons. The first and simplest one is just that part of that subspecialty, I think to do rhinoplasty, you have to do almost exclusively that, to do it well, to do it to the level that I would want to be at it. It's like, that's kind of the only thing I'd have to do. And then I think part two, what your friend was saying a little bit, is just rhinoplasty gets into more of a transformative type of procedure. You're trying to make somebody into something that they never had before. It's brand new to them. It's not the nose they were born with. My practice is very different than that. I'm more rejuvenative. I'm trying to take people in a direction that they were before. I'm not trying to make them something that they never were. And that insulates me from creating the same product every time. It helps me make people more happy with what they're doing. Not everybody wants that. And that's part of saying no, honestly, and where we're sitting right now is very different demographic. People, sometimes it's a little bit of a status symbol to have this procedure from this person, and they want to look in a certain way, and that's totally fine. That's not a good fit for me. That's not going to make me happy and fulfilled in my practice. And so that's somebody that I'll probably refer to one of my very talented colleagues.
Yeah. If somebody made a living with their face and got into something happened to their nose, who would you send them to fix their nose then? Who does noses that you go, they do a good job?
Oh my gosh, there's a lot of those folks.
There is?
And as you get into this rabbit hole too, it's different types of rhinoplasty.
Wait, what does that mean?
Rhinoplasty is just the medical name for...
No, I know what it means, but what do you mean different types?
Closed versus open versus primary versus revision or secondary. And so just as a reference point, as to your friend's point, which is there's so much dissatisfaction amongst rhinoplasty patients that some people, their whole life in practice is secondary, like second nose procedures or
revisions.
Third. That's all they do, is because there's so many dissatisfied people from the first one, which is why, again, you got to be really good. You got to only do that. And so, short of throwing out names of some of my colleagues to upset others, you just got to seek somebody who kind of can do what you want. There's some people in LA who only do closed rhinoplasty, and that's their thing, and they're very wise to tell you, you're a great candidate, you're not a great candidate.
Closed?
Closed. So the incision is only under the nose. They're not the incision is inside the nose. Okay. And so they're not leaving any scarring or anything like that. And that's a different technique, but only certain people are good candidates for that. So their job is to say yes, yes, no, yes, yes, that type of patient selection.
What is the number one procedure, period, in plastic surgery that gets done?
In my world, it is eye surgery and facelifts.
So either a brow lift and a lower eye and an eyelid, and then facelift, would that not include the eye?
Yeah, so they get divided a little bit. Eyelid surgery is more common than facelifts are. But you got
I would be mad if I went and got a facelift and somehow I thought it incled in the eyes and it didn't. And come on, that never happens.
Well, that's what the whole conversation before the procedure is. Here's the unique things, because everybody's different. Oh my gosh. I see all the time just people who kind of got a cookie cutter approach, and something gets left on the table, and then they got their 7 out of 10. And they're like, oh, well, my eyes are still asymmetrical. That's a big one for me. And in my before and after photos, you'll see a lot of those little nuanced improvements in eye symmetry, which is very challenging. So we're talking about quarters of millimeters, but wildly satisfying and a huge metric of success after a procedure. Because again, you can't really tell what happened. The person's eyes are just slightly more symmetrical and a little bit more reflective of light or whatever it is. And that's oftentimes somebody had something called ptosis, with a funny word that starts with a P, where the P is silent, but one eye is a little bit smaller than the other. And when I tell people this, it's this aha moment when you take a photo, or when you're in your parasympathetic nervous system, early in the morning, late at night, have a glass of wine. People say, I get this droopy eye. Or every photo I take, one eye smaller than the other. That's ptosis. And if you get an eyelid surgery and don't correct that, it's going to get exposed or it's going to be suboptimal. And my job is to recognize that before. And that's a big part of my practice in the eyelid world is just, okay, what are these little things we can do to make things subtle but impactful afterwards? That's a big one. Yeah.
Okay. So prior to, people are coming from all around the world to Washington.
To Washington State. Yeah.
Good on you.
Yeah.
You live where you want to live and you get it done.
Yeah.
That's really an important point for me because I love having these conversations and going and learning about this, but it's also watching different people do it their way and being willing. So you're saying, hey, my lifestyle with my family is as important as the success of my business. And also I believe that if I do a really good job, it's going to work out.
Right.
And you're a great example of somebody, because when I saw Washington, I go, this must be a mistake. Like, who's going to Washington to get plastic surgery?
What you think of, yeah. Makes me better at what I do, though, being where I want to live and sort of thriving in all other avenues of my life and aspects, and being able to be in the mountains or on the lakes or in the snow. That's what fuels me as a human. And it makes me better at what I do because of that, too. Yeah,
but when you first hung your shingle, there had to be years where it's slower.
Yeah, you have a vision of what you want to build, and, you're the 10 years to an overnight success story, right? Nobody sees what happens in the beginning. And, we were just talking a little bit about having the curiosity, having the open mind, being skeptical, putting all that to practice, and just knowing that, okay, here's my capacity for what I can do. And I'm going to continue to strive and build and, have a grind, but a pleasant grind in a direction that I know I want to go. And there's definitely a little bit of that. If you build it, they'll come. It takes the faith in yourself, betting on yourself a little bit. But I knew what I wanted to build, and I knew that I had people that would resonate with that, and that's where I'm at now.
Yeah, but it is a good reminder, because I think a lot of us think there's only these specific ways to do things, and it doesn't mean it's an easier way, but in the end game, I think it ends up being the only way.
Yeah, it can be really uncomfortable.
Yeah. Did you get a message and then I'll move on from it? Did you have an instinct and you go, no, I know this is going to work? Sometimes I think people get whispers from the gods, from the universe of like, hey, you're in the right path? Or was it like, no, I'm going to do it this way and we'll see what happens?
It's funny. There's a lot of soul searching, praying, whatever you want to call, that goes into what you want to do. And I definitely had those moments, and I continue to have them, actually. But it was, a decade ago now in my life, a little bit more than that. And it's hard to reflect back on if I felt like I was forcing it or if I felt like this was a calling. It was really kind of what you said before, like, this is where I want to live. This is where I'm going to be my best self, my happiest self. I trained in Los Angeles. I could have lived here. This is an incredible place, right? But for my family and my wife, Aubrey, and I knew this is where I wanted to be. And, a great product is a great product if you really get down to it. And I knew what I had, and that was the sort of faith that built everything up in Washington State. I actually live in Idaho, so it gets even more off of what people would expect. Yeah.
I can't wait to see when people are going to come to Idaho to get their face done by you. It'll be great.
Yep.
It's probably only like 5 years away or less.
Right. Yeah. Coeur d'Alene's a beautiful place.
How long's your lease right now on this building?
Yeah. I'm already working all over both
exactly.
places. Yeah.
So prior to, what's the customary amount of time? 3 to 6 months before somebody, they call, they get some kind of consultation with you. Is it typically about that long?
Yeah, it is. It depends a little bit on where we're at. But by the time we've spoken, we're already usually a few months into the preliminary process. And then we kind of make a decision, however quickly it is for that person. And we have, usually 3, sometimes 6 months. Mostly depends on their schedule. I'm very protective of mine in the sense of I only do 1 surgery a day. I don't go back to back. I could easily do 2 a day, but I tend to lose some satisfaction, and I feel like I may lose a little performance in the second surgery, so I'm not about to compromise that. Mm-hmm. My internal obsession with my results wouldn't let that happen. If I thought, this is going to be 1%, nope, not going to do it. I want to get 1% better, not 1% worse every time I go.
Are you? Most doctors have like 2 days a week or so they're doing surgery. Are you going all 5?
No, absolutely not.
Okay.
2 or 3 days a week. It's the same, this is where you get into that athlete's mindset. You're not going to pitch or play or do whatever every single day. You can't get up to your peak performance. My entire week revolves around those operating days, what I'm eating, how I'm interacting with my family, what my workouts are, how I'm sleeping. I'm tracking all those closely, whether it's my glucose monitor or my heart rate variability or my sleep, whatever. I'm really trying to get ready for that day. First thing I do when I wake up in those mornings, have my quiet time, check, okay, what are my metrics today? And it's just honestly usually positive reinforcement that like, okay, I'm at peak performance, I'm ready to roll today. And that's not a mindset that's typically common among surgeons. It blows my mind that it's not, because for you, it's a big deal for me, but it's a massive deal for you. You don't do this hundreds of times a year, This is your one time.
Yeah.
And that is not lost on me. And I take that very seriously. It's part of that relationship that I was speaking about before makes that even more powerful a lot of times, because I understand, I feel that from you. And so I want to be at peak performance. I can't do it every day. I can't do it twice a day. It's like, I'm up, I'm ready. It's my masterpiece that day. And then I'm in recovery mode. I have a whole flow state preparation that I get into every day before procedures. It's very routine for me now. I'm still honing it after a decade, but I'm up early. I have my quiet time. I'm in the hyperbaric chamber, consuming, reading, learning. Then I get in a sauna and have a cathartic workout and inside the sauna and have some quiet time. And then I'm flowing. I'm like, when I walk into that operating room, I'm in my place. And that's what I would want for my surgeon if I were having a procedure. And so it's a big deal for me to get there.
Well, you have 3 little kids.
Yep.
And kids, they do what they want to do.
Yep.
Do you have a system in place where they can't rock your boat before you go, or you just...
No, I mean, there are opportunities for growth and resilience building all the time. Probably my biggest one.
Is that what you call it?
Right.
I got to adopt that phrase.
Well, I mean, you had this conversation with PJ about banking all these things you do that are hard, and having this little, thing to look back on, this pile of whatever you've done. And for me, when I heard that, I was like, well, that's parenting for me, a lot of it. Hard conversations, difficult things at work, surgeries, workouts, holding my breath in the pool, whatever it is. You have all these things you can look back on and you're like, okay, for me, parenting is a big one of those. It builds a lot of resilience, grit, perseverance. You guys broke those down really well as to the differences between those. But I'm going to be a dad first and foremost. I'm going to be a husband. Hard things happen in life. You have disagreements. You just build the resilience to roll through those so that when surgery comes, I'm essentially unaffected by those, emotional output, physical output, those all matter. And it all kind of plays into your whole. So maybe I have a tough emotionally output day, so I'm going to change my physical output, or maybe I'm going to do more, kind of whatever I'm feeling to be at that peak performance.
I think that's a really important point to highlight, because I think sometimes people go, well, I have a plan and this is what I was meant to do. And they don't actually check in and go, is that plan still going to serve me today? And so to your point, if you are emotionally, for whatever reason, tapped, and you have scheduled a pretty rigorous activity, maybe you go, today's not the day for that. And I think it's so interesting that people, especially people who are organized and scheduled, and they're used to that, they're actually the worst in certain ways of saying, oh, wait a second, it would be better for me to go take a chill walk or go with loved ones and be in a restorative state versus, well, I had a plan and I was supposed to do a 25-mile ride. Right. It's like, yeah, well, today's not the day. So I really appreciate that. So you talk to them. Maybe do you sort of try to control the month before they get to you as far as nutrition and what they're doing?
At a minimum, I like that month beforehand. And like we were talking about before, a lot of people are already doing these things to some degree. For some, it's totally novel and new, and actually that's really fun to expose them to, we were talking about the controversial idea of seed oils and inflammation. Controversial or not, this is something I'm teaching my patients about before their procedures, their glucose management before procedures. For some people, they might need a continuous glucose monitor leading into their procedure to understand better what's going to be important for them leading into and after their procedure. I want them in sort of their optimal inflammatory state, their optimal oxidative state. When they get there, that's how they're going to be at their peak performance for what for them is recovery afterwards. I want them primed for recovery, even what type of cleaning supplies they're using sometimes. These are important, seemingly novel aspects to some people. Others are doing it already, but I like at least a month of that before they're coming in. And I think it just makes people honestly more invested in their recovery too, because it's like they come in feeling like they're a professional athlete. Like, I've been training for this, basically. Great, me too, let's get ready. I've been visualizing their procedure for weeks before it's done. I have this constant cycle that I'm on of outcome visualization, process visualization. athlete's mindset, right?
Yeah.
It's big, and I want them to be as invested as I am in that part.
I wonder if you have any patients that lose weight before they come to you. I mean, just, if they're kind of beginners at certain things and just taking out a few little habits, they get a pretty instant feedback, I would imagine.
It's so funny. Yeah. People just feel, I hit her all the time. People are like, I feel so much better over the past 2 months that I've been getting ready for this. Regularly hear that. And it's, again, usually people who already know some of those, so they're already doing them, but it's kind of going all in a little bit for this big event.
Yeah.
Like you were talking about smoking. For some people, that's a huge deal. To quit smoking tells me this person wants this so bad. Well, it's the same if you can change your lifestyle and your diet to that degree. You want it bad. Yeah. And people feel better, and those are things that they continue afterwards. I have patients who, I get a little concerned about their metabolic state. We put the glucose monitor on them before they come, and you have type 2 diabetes full blown. And so we're going to optimize that. Your whole life is better now because of that afterwards. So it's a co-investment going into it together, and it's a bonding experience, because when that person shows up surgery day, kind of like you with me, I know you without knowing you, right? I know this person without knowing them too, because a lot of times it's the first time we physically met.
Right.
But I think a lot of people think they're going to come in that day and we have everything planned out to the T, and we're going to like high five and go into the operating room. Or I have some colleagues who show up for their surgery and their patient's like already asleep and prepared by their fellow or by their staff. That doesn't provide value to me in the way that I want to. I want to give you a hug and chat through everything that we're doing today, inside out, kind of redoing the consult almost. And much to my staff chagrin, it's often 2 or 3 hours that
they're like, wrap it up, doc.
Well, I'm meeting with you for the first time. You traveled here from Germany or California or wherever, and I'm not like, let's have a first date before we go off to the
you don't have 4
room.
sleeping bodies that they just roll in one after the next.
That's that quintessential idea of like, lining up cases and hammering them out and just kind of getting through it. That's not satisfying.
It's interesting because you're in a business that also, as far as like doctors, this is a money-making area. Yeah. It just is. And it's interesting because you're still managing it where you're creating, I mean, you can increase your cost, but there's still, no matter what, you're choosing less as part of your success. Because just as far as numbers and hours, and you're sort of writing that into the formula for you of what's successful.
And that is part of just my overall look at that, of who I am in an identity standpoint too. I'm not just a surgeon. That's a part of it, and I love that part of it, and that's a lot of where my outlet for my competitive spirit and those things are there. But if I'm doing that to a point where I'm breaking down the rest of my life, it turns into this vicious cycle downwards. And I don't want that. I want it to be a vicious cycle up. I want it to be bubbling up all the time, getting better in all aspects of my life, and this is a great outlet. So you're right, you're balancing all of those things together, but it's also very like medicine in general, I will say, but especially what I'm doing is very satisfying. I get to help, I get to be creative, I get to apply, I get quite literally a feedback that's visual. It's not even I just feel better. It's like I get to see it. And so it's very satisfying, and I don't want to compromise those things. So it's a quality quantity balance a little bit.
Have you ever been flown somewhere to do a surgery?
I don't operate outside of my little dojo that I built.
They haven't brought you to Saudi Arabia yet?
I get those offers to do that all the time. Just even this morning, you want to travel to Dubai, and like, well, my patients will travel from Dubai to me. Well, I don't want to go there. I don't want to be away from my family for a month. It's like, come to my space that I built for this and experience this. That's much happier there, and I think I'll perform better there too.
So I'm on the gurney. We've hugged it out. You have a sense of how crooked or high or low my bones are, and now it's time for surgery. And even in the first part, you put headphones on your patients, right?
Yep.
And so maybe just walk me through some of the unique things you do in getting the patients prepared, and even how you put them under.
That's
different.
Very different. Yeah, it is. So we get to that point where, we've planned everything out. We've gone through every detail again. It's kind of fun to it's a fun little playful back and forth as we're drawing and getting to see the art that I put on your face kind of idea. We go back into the room. I'm in my flow state. You are comfortable now. I've got you out of your sympathetic nervous system into your parasympathetic just by the relational part of it. So it's just a better setup. I'm thinking about your anesthesia part of it now, because that is scary and big and huge. I just upfront do not use general anesthesia for these procedures because I don't need to. And then I get into the sub-levels of that, which is I don't use opioid medications. I don't use benzodiazepines. This is very rare types of a mindset, because those are all neurocognitively suboptimal. There's some insult to your brain when you do that, or even with opioids to your gut and your urinary system and how you function after the procedure. So I'm using medications that are not creating nausea, that aren't blunting your neurocognitive effect afterwards. Very different mindset, right? But before we even do that, like you're saying, I put in headphones that have binaural beats in them. So it's creating this specific brainwave that I'm after, delta and theta waves, and I kind of alternate through them to get from a more awake state and transition into a more sleep state. I need less anesthesia when I do that, which is a win overall, huge win overall. It's more comfortable and relaxing to go to sleep kind of on your own brainwaves than having a drug put you to sleep. And so this is kind of part of it. I put the headphones in. I usually sit with the patient at the head of their bed and just kind of rest my hands on their shoulders, and we just kind of have a moment. We just chill a little bit as we start to get into that state. I mean, even just having, I think, the physical touch of like this person, it's, again, big relationship. It's comforting for me. It's comforting for them. It's not get you in, slam you back, put you to sleep, let's get this over with. It's like, this is what I'm doing all day. And it's such a wonderful feeling, you know. When I say all day, sometimes it's all day, but I mean, this is my only focus right now. I got nowhere else to be. And so it is a little bit different in that mindset.
This is very undoctor of you, I just want to say.
Yes, this is me. Yeah, it is.
I know doctors would like to be more like this. It's just set up usually that they can't be.
Right. That's true. And that's systematic a little bit. Yeah. And I get to project my own values a little bit into this too, and things that make me happy. And part of it is what you mentioned, is just that I'm not driven by insurance reimbursements and this is and that's. And I view the quality as more than the quantity for myself. So
once a person's relaxed, how do you get them? I mean, you're going to take parts of their face, move them around. Like, they have to go to sleep.
Right. Yep.
So what are you using? Are you allowed to share that?
Yeah.
Okay. And then how do you have the courage to go outside of, well, this is protocol. People use anesthesia. This is what they do. Then they give pain pills. Like, where did this come from, and what is it? This
is just part of, a lot of these are just driven by your capacity, right? What you have available to you, how much outside of the box you can think, how much better you want to get. This is where innovation's uncomfortable and progression's uncomfortable, and you have to be able to handle those things. I have my repertoire that I've built. I have that pile of things that I know I can draw off of in these situations. And so it just takes a little bit of outside the box thinking, and thinking from a different mindset, more holistically, like, well, what's better for this person afterwards? Clearly, protecting their neurocognition for a elective cosmetic procedure holds a high value to me. It is more difficult to do it that way. I have to be more skilled in my surgery so that it's not stimulating. I have to be more skilled in the type of local anesthesia that I use so that it's not uncomfortable. And those are more challenging, right? I can't be as aggressive, or I can't be fumbling over things. It has to be very intricate and very delicate to do that. Well, I have that capacity, so let's do it that way. And that leads to more comfortable recoveries afterwards. As you sort of mentioned, I don't want to use opiates during the procedure, and I certainly don't want to use them afterwards. With a well above a 95% success rate, my patients do not need any opioid or narcotic pain medicines after their procedures, which is a very different mindset. Yeah. And I do that by the type of procedure that I'm doing during the procedure, just being delicate. And then the very last thing I do in the procedure is utilizing long-acting nerve blocks with a local anesthesia that lasts about 72 hours. And I go to the local nerves and I just put a little bit right around there. The person's already numb, they're still asleep. And so as they come out of their anesthesia, the nerves that would be giving the sensation of discomfort are blunted. Yeah. And
the storm of pain.
Right, exactly. Right. And the fact that the surgery was delicate and they had local anesthesia during the surgery already decreases their pain threshold or already decreases their pain curve afterwards. So they're less likely to need it there. Most postoperative pain, worst in the first 24 hours, we're definitely through that point. And so it's just I'm not going to say it's a wonderful puppy dogs and rainbows recovery,
Sure.
but it's
surgery.
It's a much easier process to get through than being uncomfortable taking pain pills, not being able to go to the bathroom. It's like, 7 minutes after we're done with our procedures, my patients are able to walk around and carry on a conversation because neurocognitively they're intact afterwards.
So again, I don't know if there's some sensitivity. What makes them go to sleep?
Yeah, so the medications that I'm choosing are things that some people have heard of, propofol and ketamine and something called Precedex that acts on your central sympathetic nervous system. So I'm really kind of taking multiple angles at calming down. And again, these are just, the analogy that I like to use with my patients is that general anesthesia takes you from being awake above the water, if you will, and pushes you to the bottom of the ocean. And then you've got to stay alive. And that's what the machines are doing for you. They're keeping you alive. I'm taking somebody just underwater, just from a consciousness level here in this metaphor, just underwater. And I'm trying to keep them right at that just underwater. So they're not too deep, but I have to be careful when they're just underwater because they could theoretically get stimulated and wake up. That's where the surgical skill comes in and the local anesthetic skill. So I could do all of these procedures with just local anesthesia, but then you have to go through from a consciousness standpoint of just being chill for hours. And some people can do that, but most would rather just, let's just get right underwater and there's your chill. Yeah. And we can do the rest with the surgical technique and local anesthesia.
I mean, every time, we've had a few surgeries in this house, I have a fake knee, and that's the thing you're most scared about.
Right.
And you're trying to figure out how quickly can I get this stuff out of my system? How can I recover as quickly as possible? Mm-hmm. So was there ever a time that you did it the more traditional way and then kind of slowly worked your way into this protocol?
Yeah, in training, you tend to do
what they tell you to do.
Yeah, you tend to do what's happening because you're sort of lower level. But I pretty instantaneously knew that how I kind of wanted to approach that. And that, again, that mindset's been with me my whole life as a nutrition major and an athlete and kind of being interested in wellness and longevity. So even in training, I'm thinking there's ways that we may be able to do this better, but you do get hints from other people. I trained at UCLA and I worked with 28 different surgeons, and you see in private practice and academics in Beverly Hills and Westwood, and you see different little nuances, and you start to realize there's more freedom to change things than you might think when you're in this very rigid academic environment. So that was just motivating. And then it turns into, what can we change? How can we make this better? What's safe and what's simple? And my fellows, I have two doctors who work with me for a year. They come in, they immerse themselves, and they go out into the real world. We kind of are always like, okay, what's our little nuanced change that we're making for the better today? What are we trying to get better at today? And there's always these little 1% that we change. So nothing's too drastic, but I'm always looking at what happens here. How do we make this a little bit better? And so getting back to the root of your question is, this has been with me for a long time, and I've seen the traditional ways, and I have evolved this all the time. My current anesthesia desire to improve is sort of okay, now I'm really thinking about people's sleep cycles. How do we get to optimize their sleep in the week after their procedure, which is an afterthought. Nobody's thinking about that, but
really help
it's
recovery.
Your superpower to recover from going back to the mindset of an athlete. You have a hard workout, you better hope you sleep well that night, right? Yeah. So I want to get into that with my patients, and I'm working on these things already with trying to, look at brain waves and get their sleep optimized afterwards. That's the current experimentation.
Great. Well, and it's not status quo approach, which I really, really appreciate. Now, the first time you're using a version of the protocol you're doing now, how do you figure that out?
Because it's small increments to get there. It's not just a drastic.
Is it on but it's not doing it on are you doing it and putting it on somebody and not letting them go through surgery? How do you practice sort of putting somebody in a more rested or sleep state and you're not doing surgery? Do you have to do that first?
So the way that it kind of goes is you're working through a more normal protocol, and you start to see the things that make you need less anesthesia. So going into the headphones, simple intervention, no penalty to doing that. I need less anesthesia when I do that. And then you get into the recipe of, anesthetics that you're using with your, anesthetist, with the other provider that's in the room. And, hey, can we decrease? I don't want to use any opioids today. Can we keep that level down? And what about the benzodiazepines? And you start morphing into this, we can do this in a way that is very different and highly effective and safer and creates a better recovery. So it's a slow evolution. It's not just like, well, let's just cut this out and see what happens. It's not that at all.
Well, and also I understand that I really get from you the fineness of the surgery. Like I had a knee replacement, which is hard carpentry, right?
Right, it is.
But Laird stayed awake for his hip. Mm-hmm. His doctor let him stay awake. We have the same doctor. I wasn't really interested, I'll be honest. But Laird did not want to go to sleep. Mm-hmm. So they let him stay awake. Yeah. So, and by the way, his recovery was not only the hip is easier, but he was out the door and ate a full dinner that night. You know, he left the hospital at 3:00. Nobody wants to eat after you've been put under. Mm-hmm. And so I remember they FaceTimed me and I was laying in bed at the hospital because I had the knee, and he had a giant plate of food. And I'm like, that is disgusting. Like, how can you eat that?
Right.
And I think part of it obviously was...
He had nerve blocks, probably.
Yeah, so it was great. What about it? Didn't the Chinese used to do acupuncture and do the same thing, and people could almost be like technically awake?
Yeah, that's early, like understanding like where the nerves are coming out of the spine. Yeah, and that's what Laird had, a version of that.
Yeah, it's basically amazing. Mm-hmm. And that's a little bit of what you do when you sleep, put them down.
Exactly.
So then so you finish the surgery, whether it's you know, a little more intense or not, and you actually will consciously a lot of times kind of inflame, right, the skin or the area to promote healing.
Exactly.
So when you got the idea to do that the first time, were your friends in the operating room like, are you crazy?
Well, this gets into mixing in regenerative medicine a little bit, because the surgery itself it's an injury. So you're going to have acute inflammation from that. And acute inflammation is good. We need that to heal. We can make it better. We can keep it from turning into chronic inflammation, and we can optimize the way that we march through this wound healing curve that we go through. That's the next part. That's the job. But I start that intraoperatively even. It's not even at the end. So when I'm working on an area and I've lifted or moved or replaced a fat pad, I'm looking at that fat pad. What's the health of this fat pad? Does it need more volume? I'm adding stem cells to it. And then I'll take somebody's own blood, draw it away, and turn it into, a lot of people have heard of PRP, platelet-rich plasma. Well, I use a version of it that's called platelet-rich fibrin. So it has like a little bit of the early gluing or healing components of how things stick together. And I'll take their own fibrin and kind of lay it in the area that we've worked, put the tissue planes back together, and we have an instant weld point and gluing. The bleeding control is better if there is any, and there's a bomb of growth factors delivered to that space. So I'm literally doing regenerative medicine intraoperatively as I'm working on these. And then the last thing I'll do when we get all done, oftentimes I'm using like a laser or a cocktail of lasers, I call it. Brown spots, red spots, wrinkles,
it's whatever. Like, hey, while you're down, let's hit that skin.
Yeah, and it's the only thing that's qualitatively going to improve your skin. No surgery is going to change the quality, right? So we're using stem cells from your own fat. We're using laser resurfacing. And then at the end of that, I'll use growth factors from your PRP or PRF or whatever it may be into that. And that's creating some more acute inflammation in that area. We're causing an injury, and then we're quite literally trying to boost into that acute phase of inflammation to help it recover faster. Mm-hmm. This is all the last parts of the procedure, nerve blocks, PRF injections, lasers, all those kind of go into the very end, kind of the icing on top a little bit as we transition into it.
So for general, maybe not an overly technical where you're trying to work on the asymmetry or certain things, let's just say standard, how long are most surgeries?
Most surgeries would be 4 to 5 hours.
What?
Some closer to 7.
Do you have a snack in between? Like, what are you doing?
Good question. No, I don't do that.
I don't do snacks.
Well,
you're like, all of a sudden I feel very tired.
I'm fasting for a lot of these procedures too.
Oh yeah.
Yeah. So I mean, I'm in ketosis. I'm ready. I might take my ketones before I go in or whatever it is, but I'm sharp. I want to be in that phase. And I have a very routine thing I even do with my water in the mornings. Like I wake up and I have my 40-ounce internal bath of hydrogen water and salt, and I have that. And by the time I've gotten through the sauna phase of my flow state prep, I've gotten 120 ounces of water, and might as well be 128, make it a gallon, but whatever. I do 120 because I have these, I'm getting that done. And then I know I have a few hours till I'm in the operating room and I can get all that out. There's no breaks once I go in.
But what about your staff?
They'll cycle through. But for me, I'm in it. I don't want to make my patient have any extra time under anesthesia that they don't need. And I don't want to break my flow particularly either.
Yeah, you're in it.
I don't. One of the definitions of flow, and we could get very into the details from a neuroanatomy standpoint of what flow state is, but call it neurosynaptic coherence. Whatever's happening in that state, I don't really know what time it is anyway. I'm in it, and I'm on to the next step, and I'm excited, and I'm moving through, and I'm problem solving, and I don't want to leave. I kind of love what I'm doing in that phase. So they can be long. I was an endurance athlete. I'm built for that. I can kind of get through it. I don't need to stop, and it's better for my patients if I don't, and everybody gets to go home earlier. I get to see my kids earlier. Yeah.
It's interesting. I sometimes think like your nervous system and, kind of what you put yourself through to do this. Mm-hmm. Do you say, hey, I can do this for 15 more years, and then after that I'm going to have to, express it a different way? Because it's pretty intense.
It is, yes. When I get done, and this is not unique to any flow state, when I get done, I'm pretty zapped. I need to recover after that. And that gets into the whole recovery part for me and the athlete's mindset. Sometimes I have to do it again the next day. Yeah. So there's a whole strategy to that.
You must be really fun to live with on those back-to-back days.
It's funny that you say that. My kids and, Aubrey, they know about it, and they're helpful and respectful. I mean, my kids are so into it. They're like, who's your patient today? And they make them bracelets and necklaces, and, they're not, this, like, the importance of this relationship isn't lost on them either. So they want me to be at my best too. If I was a professional basketball player and I had a game, they would want the same thing. They'd want me to be at my best, and I want the same for them in their lives. And so, it's a nice little, maybe I'm not that fun to live with. Maybe I'm going to, like this week during the Olympics or last week during the Olympics, we were watching with my kids. There was one night they get to stay up late to watch. It's a super treat, but I was in between two cases, and I went to bed before them. And so this was so cute to my 10, 8, and 7-year-old that they got to come tuck me in, and they were so excited. But they understand that's the example.
Loser?
Like they know,
Just kidding. That's how it is in our house. Laird beats everybody to bed, by the way.
Oh, really?
One of my daughters will call, and I'll say, she'll be out and just checking in, and she'll be like, it's 8:30 or something. And I'll be like, oh yeah, okay. Yeah. I just wanted to connect, before we're going to go to bed soon. She's like, it is 8:30.
Right.
So after this is the part that I also, I appreciate so much about this, but there's stem cell, there's all kinds of other things that you're doing, the hyperbaric chamber. Mm-hmm. So maybe just give and I know it's unique in different protocols, but a general sort of what's on the menu for recovery.
Right. So the day of the procedure, often towards the end, we'll do a nutritional IV. Patient's asleep, they've been fasting, and usually we'll have their genetic profiles and their nutrigenomics beforehand. We were kind of talking before after pool training about, let's say they have a mutation in their MTHFR and they don't methylate folate well, or whatever it may be. We can look at that and we can customize their IV nutrition afterwards, even to that type of a level. Has amino acids in it. I'll use NAD, I'll use glutathione, because now we're in our post-procedural inflammatory state. Let's make this go. Let's feed the mitochondria. Let's do all these things. So that'll happen the day of at the very end, or sometimes the next day as well. It depends a little bit. That's where it gets customized. How many days we're doing that IV afterwards? How many days we want to poke somebody afterwards? The next day afterwards, first day in the hyperbaric chamber, and again, a very athlete's mindset there. I do a little bit of a different dive depth and protocol than you might do for like a exercise or workout recovery. It's a little bit deeper, it's a little bit longer. But in my experience and opinion, that is hands down the most important of the recovery modalities afterwards. This is not unique to my practice. I would say anybody who's listening, having any surgery done for any reason, these are things to pay attention to. It doesn't matter what it is. If it's a knee, a hip, a thyroid, anything.
Concussion even,
right.
Protocol.
Yeah, any injury.
Yeah, and I know you do wounds.
Yeah.
Things at your office as well, mm-hmm. right?
And that was just a branch off the regenerative aspect of what I was doing. Because I have hyperbaric chambers and because I use regenerative medicine
smart.
In our community, I was getting referrals. This is not what I do, but I was getting referrals like, hey, this person has a really challenging wound. Can you help it? And I'm like, yeah, I can. I have all these wonderful tools available. And so that organically developed into like, well, this is a way for me to help the community, and I have other providers who do that.
Yeah, well, it's also low-hanging fruit. I mean, if the machine's there, if the hyperbaric's there.
Right. Yeah, we have a couple of chambers that are running all the time.
Yeah.
Taking care of
Do you get in there?
Oh, yeah. Every day. Before surgery, I should say. Every day before surgery. It's a little connecting thing, too, because sometimes I get in there in the morning and I know, like, my patient's going to be in this chamber tomorrow morning or whatever it is. But it's part of, for me, that flow state preparation in the morning. It's a little bit of a sensory deprivation situation. So I go in there, I save articles or things that I want to read for me, they're academic articles on a surgical technique or something that I find the more of those I read, the more ideas I get. Probably like you preparing for all of your guests, you get all these ideas from reading their work. I do that too. And it's so exciting that I have this time by myself, locked in a chamber, and I get to read these things. So that's part of my flow state preparation before procedure. So I get this wonderful benefit for myself. I'm in a hypersensory deprivation chamber. I get to read. It's an awesome way to kick it off.
So sort of high oxygenation. That obviously stimulates healing.
Yep.
What are, just for people listening, because I know that they're familiar with hyperbaric, and, obviously, like you met Elijah today, he has a home unit that's very different than going down, however, many depths that you can go down in the big ones. But what are what is it about the hyperbaric that's why it's helping and working? Yeah,
there's many aspects of my procedures in particular that it's helpful with. Part of it is just, like I said, generic to any surgery. There is an acute inflammatory state. There's acidosis. That changes the way that oxygen diffuses out of your blood into tissue. You can get real nerdy science with this, but there's just more oxygen flowing around. So tissues that need oxygen to do their job, to get into their metabolic cycles, have more available. They recover faster. That way it takes them less time. Helps the oxygen dissociation curve, all kinds of cool things there. But then we get into, I'm using often fat transfer as part of my procedure. So I'm taking somebody's own fat from around their belly button or their flanks or wherever it may be, and I'm putting it in the fat pads of their face to qualitatively and quantitatively improve them. This would be an alternative to filler or something if we're talking about that later on. I can get a little volume in there, but I also know that by putting their own stem cells in, because when I take their fat, I'm not just taking fat and then putting it in, I'm taking it and I'm selecting for the stem cell rich portion. I'm putting it in their fat pads. They're getting a big qualitative benefit. Those stem cells will help regulate the other stem cells that are already present and make their skin stem cells better. Everything gets turned on.
Right, it sends a signal basically, right?
We call it paracrine communication, how they communicate.
I need some of that, Doc.
Exosomes. Yeah, it works beautifully. But those cells, now we've got this free graft. We call it a graft. It's a free cell that was moved from its home, transplanted to a new location. It has no blood supply. It needs to live. So putting something in hyperbaric oxygen there helps that cell be a little bit more comfortable, get some oxygen as it's trying to establish a blood supply to itself. So our fat survival rates are better that way. It's not even unique if somebody's doing like a hair transplant, putting a hair to a new location. More hairs are going to survive if you're doing hyperbaric oxygen afterwards, because it's a physical transplantation to a new location. So lots of benefits to hyperbarics in that, in addition to just physically compressing, right? So they get in there. If I take a water bottle in with me, it's going to crush, right? So they're swollen. They get in there, and that's probably the thing I hear the most from people is, my swelling was, after one dive, was so much better. And I go to a little bit of a different depth than what Elijah's doing in his, that maybe goes to 1 or 1.5 atmospheres. I'm usually going to 2 plus. It's a little bit more benefit there. It's actually more of a challenge to get down to that depth though. So that, we have to, especially early in the recovery phase, have to help our patients get there. But so much more wildly beneficial in that to their swelling and to the amount of oxygen that we can deliver. That's where the hard tanks come in really nicely.
So you probably have people, I know you guys are a well-run machine, but it's like they're at a recovery location.
They're in a whole center that's built for this.
And on average, how long are they there?
They're there for about a week afterwards on average. Some people will stay a little bit longer than that and take advantage.
They don't want to go home.
Well, I mean, this gets into a really deep question of what does the recovery look like after these procedures. But in the first week, you've turned a really big corner by that point, especially with the help of all these modalities. Because in addition to the hyperbarics, you're doing PEMF, pulsed electromagnetic fields, and we're doing light therapy and biocharging. All kinds of different things go into that. But then by that week time frame, you're kind of a whole different person than you were at days 1, 2, 3, 4. And so it's a really great time point for people to be ready to travel home. You can fly, you're able to go. I always ask my patients when they go home, how was your trip home? Was it comfortable? Did anybody say anything? And 99% of the time, like, I can't believe that nobody asked or said.
Like, what happened?
Yeah, because.
So even after just about a week?
And you are not ready for the real world. This would be a big difference with me than a lot of other surgeons. I will never tell somebody that it's a 2-week recovery. That is not true. There's no surgery that has a 2-week recovery. Your tissues are not strong yet. And so that first week or 2 is pretty much dedicated to recovery. Now, you could work, you could be on the computer, you can take phone calls, but you're not overly exerting yourself or stressing yourself emotionally, work-wise, definitely not physically. So it needs to be sort of built into that. But because of that, a lot of people, even if they go home at a week, are still just chilling at their own house in that second week. So they may stay a few extra days to get some more dives or IVs or whatever.
Right, take advantage.
Mm-hmm.
Yeah, especially I would imagine if you have children, you kind of need to almost.
Yeah.
So what is the biggest kind of misnomer? I think there's people walking around. It's been really interesting watching everyone's an expert in beauty now with social media, and you have fillers and you have just so many different procedures that people, the greater population is participating in. So you mentioned lasers. Actually I did Morpheus too. I only did one. I know you're supposed to get like 3. I only did get 1, but and then fillers and Botox and even things like the microblading and like all of this stuff. So when people come to you, it feels like fillers have the weirdest kind of information around it, or like not the truest.
Yeah, and I don't think that there's any malintent in that often. I think it's just sort of the way that things have developed over the last 10 to 15 years with them. Because traditionally plastic surgery had this like, oh, we all know what a bad facelift looks like, or that person, you can name celebrities or something like, I don't want to look like so-and-so. They had an eyelid surgery. I think I've seen this very interesting transition in my practice. A lot of times when someone comes and says that to me now, they're attributing something to surgery that's actually from filler. They don't want to look funny like so-and-so. And when I look at so-and-so, it is filler. It's not surgery that made them that way. And that makes sense. Filler seems like this panacea of an entry point to aging, right? You just put in this magical gel and it makes you look great and it goes away in a year or two. And that was the belief, especially a decade plus ago. And over the last decade, we've really started realizing a lot of things about fillers that aren't even bad, but just need to be updated in the general thought paradigm of people that are applying them, but are still taught to this day that they go away in 6 to 12 or 18 or 24 months. That is absolutely not true. We know that without a doubt from radiologic studies looking at MRIs. We know from histologic studies biopsying tissue, and we know clinically by me seeing it in tissue that it's there for 30 years, 13 years, whatever it is. It does not just magically go away. Now it changes and it absorbs water and migrates and does all these things, no question about it. That's not what's taught, and that's not what's sold to patients. And part of it is misunderstanding. Part of it is revenue cycles. You got to come back every 6 months and get more. There's all kinds of factors that go into it. But it's this like Occam's razor idea to me, or Hamlin's razor, even being more specific, which is when you have something that's like this, is it from malice or is it just from like misunderstanding? Like don't attribute something to malice. It's more likely for misunderstanding. Like the simplest answer is probably the right answer. And I really think that's what it is that people just don't know. It's not that they're trying to be deceptive.
But they're going to put it in their face, in people's faces.
Well,
I mean,
one of my missions or goals is to make it known.
Would there ever be a time that you would use filler?
Yeah, filler has a place for sure.
Where is it?
So filler is a volumizer, right?
Yeah.
It goes into an area to add volume to volume deflation. So it really gets into, well, what part of your aging are you seeking that is related to volume deflation? Because in reality, there's gravitational change, there's qualitative change, there's shrinking. A fat pad doesn't just go from a perfect spherical circle to just losing volume and becoming a smaller sphere with gravity. It turns into, an ovoid shape and flattens out and changes. Think of a breast, right? It changes shape, direction, orientation, right?
Yeah.
It's not just one shrinking. And so to add just volume to that doesn't make sense. But a lot of people are trying to cure all aging by just over volumizing things. So if it's early and focal and one small area that's actually volume related, maybe that's only 5 or 10% of what's happening from the overall aging standpoint. That's where filler can come in and do a benefit. But you have to stop at where it's kind of maxed out in its benefit,
right?
Because it quickly gets into detrimental and makes people look funny. And that's that's the shift in my practice, is to recognizing that. And that really starts to happen as you don't understand that the filler that you did a year or two ago is still there. So adding more is now you're getting outside of the norm.
And does that go back to that dysmorphia where they go, oh, I could just do, but it migrates as well.
It migrates and moves. depends on where it's put and what plane it's in, what type of filler it is, how long it's been there, how much is present. Lots of factors go into that. It's just like Fickian diffusion from what we learned in junior high. If you put a big mass of it in one area, then the muscle moves. It's going to just diffuse out evenly throughout the muscle. Mm-hmm. But there, there's just a little bit more to understanding. It's also kind of sold as this, you can just dissolve it if you don't like it. You just put this magical enzyme on it and then it all goes away, but it's not sort of that simple to it a little bit. And so it just gets into understanding what it's doing, how things are changing, how much volume is needed there. The dysmorphia idea is interesting because it's a little bit different with filler, because you have no dysmorphia essentially, say, but you start getting filler and you look in the mirror every day for 6 months and your norm of what you look like shifts to that new filler you, right? And then you get more filler. And it's a slow change, and 6 months later, that's your new norm for yourself. But if you go look at where you were a year ago, it's not you anymore. It kind of starts looking off. That's called perception drift, and this is well defined in our field. It's a real phenomenon. Now imagine that you're the injector doing it, because that's the patient's view. It slowly morphs over years. Your just perception slowly drifts to this new norm that other people look at you and say, what happened? But you don't even notice because it happens so slowly. But now you're an injector. And so you're looking in the mirror every day and getting that feedback about yourself because you're likely getting these products.
Right.
And you have all of your patients coming in the door every day. So you're getting like this double dose of this like dysmorphic.
Did you ever see the Twilight Zone, that famous Twilight Zone episode? I'll try to keep it quick. It's genius. So it's this woman and she's had a surgery or something happened and they tried to fix her face and she was all wrapped up. And all you see is the doctor has a very smart haircut from behind, and the nurse with beautiful flipped blonde hair with her little white hat. Remember, it's the 60s. And then this patient who just wants to look at the full moon, and they don't know how this is the final surgery. They can't do any more surgery. She's wrapped up in gauze. And they say, well, we're going to unwrap it now, and we'll just see what happens. So they go through this whole thing. She has a mirror. And so then the camera is looking at the mirror. They unwrap her, and she's gorgeous. I mean, absolutely gorgeous. But then the camera pans up and the doctor and the nurse all have pig faces and everybody else in the hospital has pig faces. So that was what was normal and weird. And she looks at herself in the mirror and she's completely freaked out. But in a way, I laugh that that's so ahead because now my friends that joke, like I have a friend, she's in her 60s and she goes, I went to this gathering. I was the only one who didn't do a bunch of stuff to their face. And like, I'm the weirdo. Because to your point,
that's a good point.
Everybody has it. You have to look up. It's pretty amazing because they do it perfectly because the standard, literally full pig faces. And, she's screaming through looking like a gorgeous starlet. But I think...
Isn't that fascinating how far ahead that is?
Oh, they have a lot of that. What do we say? Listen to South Park, some Twilight Zone, a couple things. They all seem to predict all the future, right? Yeah. So if you go in and you're doing a procedure and somebody has this filler in there... What do you do?
Well, it's rare that I don't deal with filler because most people have tried, they've tried it at the baseline.
You don't usually just go get a facelift, right?
You're not
usually
right
try
to
tweak it.
Yeah, and totally fine. The norm in my field is to try to dissolve all of that filler beforehand. Just try to put this enzyme. Most of the filler is called hyaluronic acids, right? The enzyme that dissolves it is called hyaluronidase. And the idea is that you put this enzyme on. We naturally create hyaluronic acid and hyaluronidase. We're breaking it down and making it all the time. It's part of our skin structure that attracts water and hydrates. So we put this or injected hyaluronic acid in. If you don't like it, you put this enzyme on it. It magically makes it go away. Well, it doesn't work quite that well. It's not this perfect thing that gets rid of it. And then there's the question of what that hyaluronidase does to our native built-in hyaluronic acid and how you can recover. If you're 20 years old and you're highly making hyaluronic acid, probably no problem. If you're 58 or 65, you're not making as much. You've significantly declined in your ability to make that hyaluronic acid. That enzyme could mean a whole different thing to you. And then there's also this idea of there's a lot of filler in there. When I go in sometimes and I touch an area with filler, it literally jets out at me because it's under pressure and it's too much of it, whatever it may be.
Ew.
So to think that I'm going to take this massive ball of filler and put an enzyme on it and it's all going to magically go away. I use this analogy of on the carpet right here, if there was a giant pile of sand that's 3 feet tall, you're not going to just take your vacuum to it. You're going to scoop the sand away first.
So I was going to say, what do you do?
So then I go scoop it away.
Scoop it?
Yeah, manually during the surgery, I'll go take it away.
Is it gooey?
It looks like wet sugar a lot of times that's in there.
Oh, interesting.
Yeah, and it makes sense. It is a, kind of a sugar-esque molecule that's in there. So the norm is to try to dissolve it all beforehand. I take a very sort of 180 approach to that, where I say, come to me with your filler. I'm going to manually, because we're already going to be doing the procedure, right? I'm going to manually remove all the filler that I can, essentially taking the shovel and scooping it off the carpet. And then whatever's left afterwards, I'll have a really good idea of exactly where it is, exactly how much of it there is. And then I can very precisely or focally use that enzyme to dissolve right there in front of my face where the filler is sitting. And the filler will often encapsulate, like a breast implant does, where it gets this, there's some immune activity to filler. We know that inside out as well, too. Yeah. This was big during the COVID vaccine time. People would get a vaccine and their filler would get inflamed that they had for 10 years. Happens when someone gets a dental cleaning that causes a systemic inflammation, a cold, hay fever, their filler lights up, it gets inflamed because our immune system recognizes it, which means occasionally it'll get this sort of capsule around it. Mm-hmm. And so no enzyme is going to get to it through the capsule. It's like embedded in this fat pad. So I have to go manually take these little capsules out or inject them to get rid of them directly. And we can use ultrasound to do some of that percutaneously through the surface of the skin. And we're getting much better at that, but that's not
Where would it go?
either.
You'd pee it out somehow?
Yeah.
It
so
would break it out
down,
and then
it gets broken down to water and goes away.
So
it never all goes away.
No.
Even surgery, it never all goes away.
Yeah, sure. So I know this is like a side, a lot of times, like I'm so interested in the jaw because, if you, was it Weston Price, the dentist, yep. It's like big jaws, open jaws, health yep. of teeth, space, room, all these things. Do you ever talk to, like, I've been considering just getting like an Invisalign or something like that because as my, might keep my lower jaw just as open as possible. How much does your teeth and your jaw, because people, they pay so much attention to just the aesthetic, but do you ever talk to them about maybe?
All the time. This is like a super next level question, Gabby, like to get to that understanding of what it does. Our mandible, the bottom bone in our jaw, is like a horseshoe. And it's pretty thin, especially at the back edges as we get towards our ears. It's really thin. You can like pinch it on yourself and feel how thin that is. But there's also a really thick muscle that attaches there. One of our two chewing muscles called the masseter. When you bite and clench down, you can feel that muscle flex. Just like every other bone in our body, that muscle needs to flex on the bone to keep the bone density high, right? It's very trendy to put Botox in the muscle to shape the face. Well, now it's like putting Botox in your bicep. Well, your humerus, your arm bone's not going to be as strong because it's not getting as much force placed on it, right? So that's not saying that's all bad. Some people have larger masseters and you can shape them down and whatever. But yes, you have to chew food. The standard American soft diet like doesn't do well for our jaw aging even. You have to breathe through your nose. We know that inside out too. This is like talking to my patients about mouth taping. It's like mind blowing, but it's real. It changes your overall health in a bunch of great physiologic ways, but also when we get to the nitty gritty of what we're talking about, it also changes the way that your jawbone functions, right? Mm-hmm. One of my great friends is an oral maxillofacial surgeon, and we geek out on this all the time. I'm like, well, if I have my kids chew when they're really little, will they need to get their third molars, their wisdom teeth taken out? Why did that happen? So yes, again, a very next level question that not a lot of people talk about, but your mandibular density, how well you hang onto the bone affects your chin projection. And that's a huge definer of the delineation between your jawline and your neck. And so it's really important to do those things.
Yeah, I just want to bring that up because I think we focus sometimes on things that are almost secondary on how we can help ourselves and even keeping that tissue open. I mean, obviously everyone's on their phone. And this idea of trying to stay up and keeping the jaw and keeping the tongue, with a large range of motion and all these things. And I mean, there's nothing worse if anyone's ever had some kind of myofascial release or someone go inside your jaw. It is incredibly painful,
it's tight.
But it also is really, really helpful. Mm-hmm. So when because people love to hear success stories, and I know you have a lot of them, but do you have any case that really, the amount of, I don't want to say the word success, because they're probably all successful in this way, but just something that changed that really was so dynamic for a person.
Yeah, absolutely. And, a lot of people come to mind, but when I think of that like quintessential dream magic wand story, it's actually a patient from down here in Los Angeles who's a performer and had some other things done and was in not a bad place, but just not a great place, like suboptimal. I like to use that word because it's very soft, 7 out of 10s and this and that. But then and it's a very common story, which is one of the reasons that I like it. Had every resource available to them in the whole world and kind of got into a place that wasn't, not trouble, not frank trouble, but just not the best, and kind of started to realize that the perception drift kicked in and all these things. Had issues with surgery, started getting filler to make up for the issues with surgery. Like public service announcement, if there's ever an issue with anything, especially prior filler, more filler is not the answer. He gets into trouble sometimes. And so I start working with this person, and it's a challenging situation. Already baseline, very beautiful, into health, but with room for improvement there. Like, this wonderful journey there, and in a spot that's not great, but with a lot of complicating factors, prior surgery, prior filler. And then it was really getting to know her, getting to understand what she was really after, what she needed for her life and career, masks and sunshine for you, or whatever it may be. And then really putting together plans like, okay, here's what's the things that are a little bit more challenging that we probably want to and need to do. Here are the things that were just maybe missed or low-hanging fruit from before, and putting together this small but relatively complex plan to make everything come together that was done before. And in the process of that, getting some really great insight to health and longevity and genetics and nutrition, and then really bringing that all together and executing a very minimally invasive surgical plan. A lot of people everybody's seen this person, and nobody knows anything at this point. And it was kind of like a rescue from... Sometimes
I see people and I'm like, they had something good done after something bad. I have seen that. And you just go, they fixed it, whatever it was.
Right. Yeah. And you start getting the feedback like, so-and-so's back. They look like themselves again, or whatever it may be.
Oh, yeah.
That's positive feedback. And again, this happens great. Not just in that happens a lot of times. Sometimes it's somebody who's never done anything. And I hear this a lot too. I would never even have considered this. Then I kind of found you, and I just resonate with who you are and what you say. And, you just know that vibe a little bit. Sometimes it's like, yeah, I get that. Like, we can do little things and have impactful differences and not have any thises and that's, and be respectful. I usually say, be respectful of a baseline.
Yeah.
And kind of, we were talking about keeping a balance. To me, that's being respectful of where you started and not transforming and just rejuvenating. And so a lot of times I'll get that too. I would have never even thought of this. And I met or saw you or whatever. Then boom, next thing we know, they're like, I'm so happy that I did this. And those folks have never done anything usually.
Yeah.
And they just get to this place that's like, it gets very controversial. And I hear this all the time. This person didn't need any, like, if you had a procedure done ever in any way, shape, or form, people are going to say, what are you doing? You don't need anything. You are so beautiful and so this and that and the other. And that's really not appreciating the complexities of how our life goes. And we were talking about this earlier with Laird too, just the feedback mechanisms. And, I really equate it to this. For a lot of times I'm part of somebody's wellness journey a little bit. They just want to feel better about themselves. Look how they feel. And it's not a perfect analogy, but your knee hurts and you could live with it.
Yeah.
You don't,
well, listen, I always say too, like, I don't want angry face, because I don't feel angry or like, all that sad. And you realize, like, if it heads in that direction, I'm going to figure out the way to take care of it.
Right.
Because it's not matching. But that's not fighting where you are. What I get nervous about when I see people, it's like, everyone's mad whoever got a facelift in the 80s. I'll tell you that. It was like, whoa.
Whole different procedure.
You can't blink. You can't. It's just a crazy thing. So I do really appreciate, especially because now that I'm middle-aged, it's like the perfect pocket. But Botox, if a friend came to you and said, I'm thinking of Botox, how do you feel about it?
I'm not strongly opinionated in either way on that as much. There's the idea of a toxin going in your face and, creating an immune response to that, which we tend to do over time because not as much with cosmetic applications, but with muscle spasticities or things like that. When people get large doses, we know that eventually they become immune to it. So there's an immune response that happens with it. But on a cosmetic level, it's very low dose in comparison. We're talking about an order of 1 versus an order of 100 types of units when we get into that. And it has an effect that is pleasant when used properly, which is my idea with that would be low dose, diffusely put in to not freeze anything. You don't want a muscle not moving. And that's what it's intended to do, is like make the muscle not move as much so it doesn't put as much stress on the skin. Then there's not this tug of war happening where the skin's losing and the muscle's winning. But at the same time, the other part of me, and that's good and it works and it truly is temporary and this, that. But then on the other end of that is, well, we almost touched on this a second ago, our brains are very wired to recognize nonverbal facial expressions. And there's parts of our brain, it's interesting, we get into our temporal lobe of our brain and there's 2 parts of it, the amygdala, deep, more central part, that would be, more primitive, is emotional regulation. And then we have this fusiform gyrus, also in our temporal lobe, that's a little bit more superficial. So theoretically a little bit more higher thinking, and that's recognizing more of the nonverbal parts of our facial communication, recognizing how old somebody is, if they're beautiful, if they're going to hurt you from an emotional standpoint. Babies use this to recognize their moms with no concept of beauty, right? That gets into the whole neuroanatomy of beauty, which is different. But we're so exquisitely tuned into people's faces, right? And this is where you get to a little bit a second ago where you're like, you don't want to have mean face. Well, okay, well, let's keep this in bounds of how our amygdala and our fusiform gyrus are recognizing faces, and we can have these little micro alterations in what you're putting out into the world a little bit. But back to Botox, is that can change that perception a little bit. And there's studies with moms and babies, and nothing is like really solid to say you shouldn't do Botox. But I think it's just back to your individual value system. It's very great entry level. It has an effect. I might, for people who don't want that, I might say, well, okay, instead of focusing on one end of the tug of war, weakening the muscle, let's focus on strengthening the skin, which is another great way to go about it.
How do you do that?
Well, you can do that through all kinds of internal mechanisms, which you've had guests on here talk about before, and that's awesome. You can do it through external mechanisms of fat transfer, which we talked about, to make the stem cells from that make your skin stronger. You can do it with lasers and devices like that. Anytime this gets into a public service announcement a little bit, but anytime a laser or a device promises to lift something, run, don't walk away. That is not going to happen. Morpheus is often sold as it's going to give you a lift, right?
Oh.
It's not going to lift, right? We're talking about changing quality by applying heat to these things. Morpheus is with needles under the skin, giving radio frequency heat. Lasers use specific wavelengths of light on the surface of the skin to change things. And you can certainly have a qualitative effect, but nothing's lifting with that.
So what's the promise that would be, that's acceptable of a laser?
Yeah, like a qualitative
just
improvement.
Just the health look of looking, the texture.
Right, texture, fine wrinkles, things like that. Those can certainly improve. Broken blood vessels, brown spots. Things that would be like...
But no lifting. You're very clear about that word.
Right. If the duvet cover is sinking off the bed, you're not going to like iron the duvet cover and lift it back up onto the bed. You can take the stains out of it and stuff, but you're not going to get it, kind of lifted back up. That takes a procedure. It's really just understanding how lifts should work. You talked about lifts from the 80s, right? And those were very superficial, like grab the skin, pull it. Well, skin, when we think biodynamically, is very elastic. If you pull on an elastic biodynamic structure, it will eventually stretch out. And it just fails, right? Yeah. We want to pull on rigid structures, fascia, ligaments, things like that. So now our procedures are totally different, more minimally invasive, but we can actually get to the source of the let's say the decline or the descent of those fat pads. We go underneath the fat pads, we put the fat pad back where it came from, and we can fix it there. And now we've lifted something supernaturally, and it relies 0% on the skin. The skin just is along for the ride where the fat pad's going. So when we think about jowling or something like that, there's a fat pad under there that's causing that to form. It's not the skin. So to tighten the skin, you're not lifting the fat pad below. You need to really think through and just understand how that aging is happening.
It's interesting because one of the things that is a deterrent for me is I have pretty good skin. And then I think, well, what if you got a facelift and then somehow all the system that makes the quality of the skin good breaks down because you've moved it? You think about blood flow, circulation.
Totally.
So does this,
It's another next level question.
Is it though?
Yes, because people
this
don't
is really
think
my
about
consultation. You just don't know it.
Right.
No, I'm kidding. I'm totally kidding. No, but these are thoughts that I think if somebody really thought about health, they would be realistic about, hey, if my skin overall is pretty good, if I pull it, now I'm away from, do I change the vascularity? Like what happens?
100% you do. Our skin is, our skin is so bound to the fat pads below, and there's blood vessels running between them like crazy. And so an old school facelift would lift the skin away from the fat pad, and then would try to grab the fat pad and lift it up from above. The modern way to do it, and again, this is developing, and I hope by the end of my career, this is the way everybody does it, but it's still kind of building momentum, if you will, is to leave those connected to one another, which leaves all of the blood flow and the lymphatic drainage between them going. And you can imagine that separating all the blood vessels, there's more of a bleeding risk with that too. Well, right below the fat pads, there's what we'd call an avascular, no blood vessels, plane. That is actually embryologically, if we go back to how we develop as little fetuses, that's where the fusion happens and what keeps things in place. So we go to this avascular embryonic fusion plane. Underneath the fat pads is sort of like quiet in there, if you will. There's no blood vessels. You're kind of working in there. You're like, this is great. I can lift the fat pad up from below, put it back where it came from, and close it up, and all of the lymphatic and blood flow drainage between the skin and the fat pads below and the muscles under that is still intact. So this wonderful, beautiful way of doing this, it's a technically a more difficult surgery to do to get there, but then results are just so much better. And again, I think that we'll see more of this building over time. And I can do that. I can get in that plane from a little access in the temple or from a more traditional approach, whatever that person needs to get things done, you can get to that area. And it just totally changes it, because that lymphatic drainage and the blood flow, like that is everything at the end. I talked about the microvascular vessels reforming. That's the ticket to healing, right? Yeah. And we didn't talk about this with filler, but filler, these little molecules will get in your lymphatics and they'll inhibit your drainage afterwards. When I consult with a patient who's had anything done prior, the 3 predictors of swelling that lasts longer than normal after surgery are going to be a prior history of fillers, because we know the lymphatics are drained or blocked and it's going to attract more water, prior surgery, because there's often scar tissue from that prior surgery, especially if it was an old school surgery that's more superficial, more aggressive, then just maybe more advanced age or bad, cardio,
being old.
Yeah, vascular health, basically. Yeah. Being old. Yeah.
Would you, I know this is a weird question, but would you ever get anything done? So it's interesting. I think about someone in your position, and you're here to make everybody look better, right? And not in that order. Maybe they look better, then they feel better. Okay.
Chicken and that is the egg, right?
That's part of your business.
Yeah.
And what's interesting is you do have a very robust online presence, and part of it is your ability to communicate. You are fit, you're healthy, you obviously live what you preach. I experience this. I'm supposed to be fit, and you go, okay, but then there's a reality to things. Okay, 40, 50, 60, 70, 80. So the pressure isn't to be perfect, but the pressure is to kind of look the part, right? So let's say in another, 15 years, let's just say you're young and healthy. Would you ever yourself get anything done?
Absolutely, yes.
You would?
Yes, but it has to sort of adhere to this value system of mine, right? Absolutely.
Who would you let do your surgery? Do you know them?
I don't know. In 10 or 15 years, probably
could be someone in school right now.
Probably one of my fellows that I trained, honestly, because at least I know how they're thinking, and hopefully they've taken what I've given them and run with it and made it better. Like one of those people who starts with a baseline foundation. But the answer is yes, because in your 50s, right? You look better in your 50s because you're healthy than if you didn't, right? We know that we could look at your metabolic aging, we could look at your genetic aging, we can break those things down and check them out. And we know that will have a predictive value as to what your facial aging looks like. But there's a mismatch, a decoupling there a little bit. It's not a perfect linear relationship, right? So you can make your metabolic and genetic health so healthy, and your face will look better, but it's not going to be to the same degree.
Right.
Which is still great. And that's part of what you have going on for you, and part of what I hope to have going on for me too. But then as that decoupled mismatch goes down the line further, that's where it gets into like, okay, well, now I don't look like I feel. That's what people are telling me without knowing what they're saying. And at that point, it's like, that's, again, it's what you're putting out into the world. If it's, this little minor, minimally invasive, scarless thing you can do to have an improvement, they're just like, I feel better.
Yeah.
You know, I'd look in the mirror and I don't have this, that, or the other that kind of bugged me before. It didn't, like, I'm way healthier than that. You know, when you look in the mirror, well, that's the time to do something.
Yeah.
You know, which is a big question, is when, you know, you put me down the road 10 to 15 years, but it's when are you ready, right? When does it cross that value threshold for you? There's advantages to doing things younger.
A little sooner, right?
I mean, it's more, if you do things younger, you need less surgery.
Right.
And you get to a better place than you would. I can always get you better at 54 than I could at 64, to a better end result. And it makes more sense, right?
Mm-hmm.
You don't, at 64, you don't want to get to the same place that you would have gotten at 54. It's too dramatic. It doesn't look the same.
Yeah.
And so at 54, we get you to a better place. It's going to last longer because you have better tissue. Inherent tissue quality today is as good as it will ever be. It's going to get worse tomorrow. Sorry.
Yeah.
You know, so you do it early and then it lasts longer, and you need less surgery. So less surgery, better outcome, lasts longer. If it crosses that value threshold for you, it's probably time to do it. The idea of waiting till things are worse to get a better value is very flawed logic, because then you have that whole interim time that you could have, you know, amortized your investment out over, basically, or kind of enjoyed the results of it, that you're just waiting, you know, and that doesn't make as much sense.
So the neck,
mm-hmm.
the neck,
the hardest of them all.
Neck.
Mm-hmm.
Do you ever have anyone coming in who does like lower jaw and neck only?
So good question. Lower jaw and neck would be one of the areas that people come in and they say, this is the most bothersome thing to me. And my job then becomes, okay, I hear you. Let's explore that a little bit. Again, nobody is going to have lower jaw and neck gravitational descent and aging that doesn't also have it in their midface and their brow and other areas like that. And so if somebody takes their fingers and puts it on their face, a lot of times, for a lot of people, I can tell what they want just based off of that. If it's 2 fingers versus 5 fingers or whatever, I can get an idea.
They have their whole hand
right?
Shoving their face
when it's this, you know. But if almost anybody notices, if you put your fingers on your cheeks and elevate your midface, you start to get this line where your midface and face are elevated, but your brow and temple are still sinking against it. And we've all seen this without knowing it. When we see somebody out of facelift and there's this sort of like bunched line or straight line across, you're like, something's off there. I don't even know what it is, but it just clicks that part of your temporal lobe. They're like, this doesn't make sense. Well, that's what happened usually, is they got a lift from below and everything else is still sinking from above. So my job with that person who wants the lower face and neck lift is to look at their gravitational descent as a whole and say, okay, we're kind of dealing with a sinking rubber band. You're not going to take a sinking rubber band and push the bottom up. You're going to pull it from the top, but you're probably going to pull at multiple points to fix it up. That's the elasticity of our soft tissue makes that work that way. So we often have to, and this is where I'm going to be different than a lot of other people. If you go to somebody and say, I want a lower face and neck lift, guess what you're going to get? A lower face and neck lift, and it's going to look off.
Yeah, and because they have 3 or 4 surgeries that day anyway.
And it's not a higher level of thinking into it, and they're not considering you for who you are and what's going to be your best outcomes. They're maybe not as obsessed with their results. It's sort of just like they want to make you happy. And that's not wrong either, because a lot of people that get that procedure done are walking around perfectly happy. But I look at them, and on some level they know too, like, well, this isn't perfect, but I'm really happy with it because my metric of success was checked.
Right.
I just can't get myself to do that for my sort of obsession with what I'm looking at. You know, I wouldn't be satisfied with that.
The neck is tricky, is it not?
The neck is tricky. And the reason the neck is tricky is because it is the most downstream of all the gravitational change. Your brow, your midface, your jawline all play into what's happening in your neck. And a lot of people think that their neck is saggy or sinking because there's extra skin and because they have fat in their neck sometimes for people that are a little heavier. Well, very rarely is it actually a bunch of fat in their neck. It's that the contents, we talked about this earlier, our mandible is a horseshoe that's hollow in the middle. And you were talking about tongue positioning and the floor of the mouth. It's kind of like our pelvic floor, but the floor of our mouth, it ages and sinks down. And as it ages and sinks down, so does the contents of our mouth and our tongue. And it gives that fullness that's under their glands and things sink down. So if somebody just goes and gets liposuction in their neck, they think it's going to lift their neck. It's flawed logic from the get-go. It's not skin and fat that's doing it. It's everything sinking down.
Falling down.
But if we can go tighten the musculature underneath, lift the contents of the neck back up, we now actually have our neck angle rejuvenated, and any gravitational things that have sunken from above can be lifted from above. And now you've created a nice, normal, natural-looking jawline that didn't just skeletonize all the superficial skin and fat away. So it's just it's a paradigm shift in sort of the logic of how we're approaching the neck a little bit.
When you threading,
Yeah.
I see that.
Hot topic. Yeah, definitely a hot topic up with filler. It's just sort of one of those,
it's very
putting in a thread that used to be permanent, now they're dissolvable, on something that's still fixed in place. The tissue is fixed from below, kind of like we talked about when they're kind of laminated together.
Yeah.
You're not going to take something that's fixed in place and superficially pull it up and get it to stay or do anything. So you won't see, in my opinion, you won't see a durable thread lift result past the initial swelling of getting the procedure done. And that's what most of the before and afters you'll see are, and that we could get into a whole topic on false before and after
pictures.
photos. Yeah, you can do anything. I could take a picture of you now and in 10 seconds and make it look like the most incredible transformation of your life, right? Which need to be an informed consumer when you're looking at that. And you often know, like, these photos don't even look the same before and after. Don't bring me that garbage, basically. Yeah. And not saying that every thread lift result is that, but it's not a durable thing. It's flawed logic again, in that sense.
I just have to quickly ask, you have a kind of body, like cellulite treatments. I know someone else might do that at your office.
Yeah.
I'm just curious because that seems to be an issue for a lot of people. What is out? I know it's...
Yeah, it's a funny thing that you bring that up, because that, you talked about the wound care before, just kind of getting glommed on as this like side thing that is regenerative medicine based. That's sort of how the cellulite thing happened too. I don't do anything off the face.
But is it a machine, or is it like, what are they?
It's like a mechanical release of the bound down. It only works for certain types of cellulite lesions. It's more the like dents, if you will, than like the textural change.
I see.
So those dented areas, especially, let's say you're 29 years old, peak fitness, have 3 dents on your thighs or bottom or whatever. This is like a wonderful treatment. You release the binding, which is part of the issue, but then the regenerative part comes in. This is where I came into. This is like, well, the binding breaking is great, but you need to like fill that space with something regenerative now to help it heal in and fill the space, which that's where I sort of developed the next step of it, really, because a lot of people were doing the cutting, and their results were like, it's okay, it's a little bit better. I'm like, well, you're missing this one step that I can extrapolate from my facial practice, and that's where that sits now.
I know you're not going to prescribe to people supplements, but if you sort of felt for yourself, or for your lovely wife Aubrey, like, hey, these supplements, let's forget about health. Let's not talk about vitamin D or anything like that. And I know health and skin are connected. Is there anything that you are interested in supplementation for either the integrity of the skin, the lasting collagen? Is there anything like that?
Yeah. So most of this answer, I'm going to kind of skew to this idea of that your best opportunity to do that is when there has been a stimulus to the skin, right? A laser stimulus, a microneedling stimulus, something like that. That gets us into a phase where we have at least some degree of acute inflammation that we've created on purpose, that we can make a dramatic change. It doesn't have to be something crazy, but any little bit is going to force in that direction. With my surgical patients, my answer to that would be like peptides. I'm using peptides for their surgical recovery. Different ones for different purposes, but in general, there's a little recipe that I like to follow that I start them on before they come. So supplements are like a nice little adjunct, a supplement, if you will, to the process, but I like to start their peptides, and I like to start a stem cell mobilizer before they come see me. And then those carry into the post-operative period afterwards. Really important. I start to use some proteolytic things that help them in there, because there's a lot of recovery going on, so I'll use those supplements after their procedure. Some of those apply to the collagen and elastin question for the skin as well, because they help you build those things up. The cell that makes collagen and elastin is called a fibroblast. It makes these fibers in our skin. Collagen is the hot one. That's the one that, you take collagen supplements and you theoretically build more collagen. There's studies that show that. I'm still a little bit broken down on how that mechanism is, because we know that when you eat a protein, you break it down into its individual amino acids. Which is why most peptides have to be injected. They can't be eaten because they'll just get broken down, right? So I'm like, well, how is collagen then? People think that you're going to eat collagen, you're going to have this molecule, it's going to transport across your gut and go to your skin. Well, it's like taking a book and breaking it down into its individual letters. It has to get reassembled into the novel, to the pages, the chapters, the entire book. Nonetheless, there's some data to show that taking collagen helps your collagen. So we can leave that for what it is. But the real one's elastin, and you said those words, and that's a very, again, next level type of thinking. Not a lot of people think about elastin, but that's the one I want to create, because that is your natural movement of your skin. If your skin's made of pure collagen, it's a scar. It's rigid, right? Elastin is what allows it to move and flex normally, to recoil. That's the one we want to make. But elastin is a delicate flower. It is more susceptible to oxidative stress, to environmental stress, sunshine. It's going to break down faster. When you look at skin under the microscope, when somebody is older, you literally see all these broken down balls of collagen in these sun-damaged areas. Interestingly, more UVA than UVB damage because it penetrates a little bit deeper because of the longer wavelength. But elastin's the one we want to rebuild. So how do we rebuild elastin? This gets a little bit into your supplement question, but also gets a little bit into just ways to do it in general, which is if you have an injury to the skin, whether that's microneedling or lasering or something along those lines, you can use your growth factors to put in that injured area. This is like PRP and microneedling as a prime example of this. And that will change the milieu of the growth factors to preferentially make more elastin. Doesn't mean it makes no collagen, but it shifts what would normally happen to be a little bit more elastin heavy than collagen heavy. Huge win, right? Right there. If we do that with a laser, it's like that times 1,000, like on fire to make more elastin tissue. And if you start mixing in some of these peptides or even the stem cells from your fat, like we talked about before, with an injury, it is gangbusters with how much elastin it makes. But we have studies that show it does not matter if there's an injury at all. I could take your fat-based stem cells, inject them into your face, and you will break down your old collagen, like the dead stuff. You will upregulate your elastin. You'll break down the dead stuff. You'll make more elastin precursors, and you will make more elastin naturally. No injury, just the input of your stem cells in your skin.
And what, you just inject them?
Yeah, well,
Come
exactly.
on,
Yeah.
Really? The other thing I loved is I was listening to you talk about how people get the surgery and then all of a sudden their knees are feeling better because of the stem cell. I just loved all that.
Yep. And that's all part of the, sometimes it's just the IV stem cells that we'll use post-operatively. I talked a little bit about this earlier, but the norm in my world is to put somebody on a steroid post-operatively. You get a surgery done, you're inflamed, steroid goes on board. This is this idea to me a little bit that stems through life that's comfortable for the patient and for the surgeon. Less questions, less swelling, less whatever. But that's also inhibiting their growth. Comfort is a slow death, right? I want to prefer pain a little bit in this sense. I don't want patients to be in pain, but I want them to go through that initial inflammatory phase, and I don't want to shut it down. So putting the steroid on may make us both feel better, but it's inhibiting their long-term outcome. And I feel that if people knew that, they would never choose to be on it. Like, hey, you'll feel really great this week, but your result down the road, even may not be as good.
Right.
Maybe it's 0.15% worse. I don't know. Is it worth it for that initial week? Up in the air. I think it's more than that.
I also feel like when you have elective surgery, you should be in pain. I really do.
I disagree. I don't want you to be in pain.
No, you're the doctor. You can be all nice all you want. I think when you have elective surgery, because it's weird. Like in the sense that if I really step back, it's like take it all together. And I say that with a lot of love, but I just know that we have to be in touch with the whole process. When we make the decision and we do it and we take time, we do it. I think it's healthy to be uncomfortable. Because can you imagine if you're like, I wanted to get a facelift, but I'm so uncomfortable. It's like, you have a facelift.
Yeah, you chose this.
Yeah, that's why I think it's healthy. It's like, yeah, let's take it. Let's go.
Well, and this maybe gets into this idea of like achievement without struggle is meaningless or not as...
and it's an elective surgery, right.
I will say that pain or no pain, everybody goes through some pain and sort of pays their dues in the recovery phase, no matter what. Even if it's not like the physical discomfort, everybody goes through a whole chrysalis phase.
Sure.
And that is challenging. It's a big neurocognitive, big emotional output to get through it. And this is, again, where I would never tell my patients it's a 2-week recovery and that you'll hear that everywhere.
Yeah.
That's just so not true. And there's so much more to getting to the end of your final result, which could take a year. And at 6 months, you may be like wedding ready, but maybe not even all the way down. But at 3 months, you're still, ready. I mean, there's all these phases of healing. Like maybe at 3 months, you still have 4% of your inflammation or 10% of your inflammation and swelling present. You're not done. You still have room to go.
Could I wear a swim mask at 4 months?
Yeah. Oh,
okay. Wayne, how long would it be that I had to have a mask off my face?
Yep. So this gets into recovery, when I think of it, I think of two parts. Their physical and then your social recovery. And you're starting to ask me about a little bit of both, but mostly physical recovery.
I could care less about the social.
Yeah, well,
like if someone's like, you look like you had, I'd be like, well, yeah, duh.
That's the most variable part from person to person. Some people, I'll see them at a week and they're like, I was great. And I'm like, you were not great. They just don't care.
I looked good.
Yeah, right, exactly. I'm like, well, okay, I'll take that for what it is. I'm glad you were out and about hiking, But the physical part of the recovery is 2 weeks generally where you're just like, you can walk all you want, go nuts, get in 20,000 steps, enjoy. And
don't huff and puff and don't bang iron.
No, exactly. Yeah. Heart rate low. I don't want, any like bearing down the Valsalva maneuver because that puts pressure on these little blood vessels that are forming, right? Yeah. And interestingly, for a lot of my patients, like you may be one of these, if I were just like, hey, Gabby, you cannot do any training other than walking for the next 2 weeks, 3 weeks, you probably fall in love with walking again. So it's kind of cool, that you just like, oh, that was really kind of refreshing.
I like walking.
Yeah.
I walk backwards.
There you go. Next level. Take it to a different place. But you usually have 2 or 3 weeks where you're only walking.
Yeah.
Why do you walk backwards?
Shout out to Knees Over Toes.
Knees Over Toes, yeah.
Because I have knee stuff, and I really appreciate his protocol, and I think he does a really good job. And I noticed, and then experimenting, and so Laird and I will go to the beach. I mean,
Are you going uphill backwards specifically, or just flat too?
No, flat, and sometimes with kettlebells. Yeah. Laird likes to go uphill. I'm reasonable. I'm pacing myself.
Right.
Okay, so I could talk to you forever, but I'll start to wrap it up. But I have to ask, you have 2 daughters. I mean, you have a son as well. But being a dad, where it's even if you're on the, quote, healthiest part of the spectrum of beauty and aging and the relationship with it and all these things, young girls developing, it's really a dance. Becoming a young woman is a challenge, and then now they have all of these outside components, unrealistic components, and listen, I'm sure you and your wife are going to do an incredible job putting systems in place, but it's still going to get to them. Just does. I mean, unless you go off the grid and live in the mountain, and that's just the way it is. So, in all that you've learned, like you've seen how many patients and how many females, is there something as a dad that you've been sort of, it's brought to your awareness to put into place in the conversation with your girls specifically?
Yeah, that's a really good question. That's a very deep question too. And my answer to that generally is I want to make them very self-confident. And there's a lot of reasons for that outside of life, but I think getting into the topic that we're really talking about here, kind of the underlying tone here, is that I want them to be very self-confident because I don't want this for my patients either, honestly. I don't want them to think that this is going to drastically change the human being that they are, right? This needs to be done for them and for nobody else. It's not to win or to get somebody back. That's like a stereotypical thing, but this is for you. This is part of your journey for you. You're ideally already highly confident in yourself. And this is like getting your knee done. Like this is part of my health journey or part of what I see and what I want to see. When I have those patients who are highly self-confident, they go through this process for them. They get better faster. They have better outcomes. They're happier with where they're at. There is no such thing as a perfect surgery. Nothing, never. I will never feel that way. I'm always striving for those little bits. And if you're a person who's the confident people are 99% better and they're stoked. Yeah. And then there's the folks who are not as confident or who, maybe did this for a different reason and all they can focus on is the 1% or the 5% or whatever it is. They can't even grasp around the gratuity of the other part of it a little bit. So maybe another answer for me is being grateful, being confident in who you are, being a little bit self-reliant, and that too, I think we talked about that earlier. That goes into this as well. Part of I've heard you say this, I want to look good for my spouse and still be virile and all this, this contributes to that as well. A little bit of that self-reliance, this helps with that.
Well, I think your wife is, is a powerful woman. And I think the idea of being an example first is always the most important. But I was wondering if something dawned on you, because I have it with my girls and it's amazing, especially girls can get pretty nitpicky about themselves.
Right.
And it's interesting if you can get them through the wave of time where they become part of what is different about them becomes different about them in the good way. Like initially we look at it and we go, oh, I'm different. And then hopefully we can hold on long enough to be like, oh, I'm different. This is how, this is my fingerprint, you know, my nose looks like this or whatever happens. But yeah, it's always a dance. Well, I have to say what's good about talking to you is I've learned so much. What's bad is it does make me way more open to get in the yank, because I've joked about it since my late 40s. I'm like, you know, and I'm not going to lie, and I'm going to sort of say, hey, if I can control the variables that I can control, I get to bed, I don't drink alcohol, all these things. Then I'm going to quote my friend Katie Hester, who said, you know, it's perfectly appropriate for a lady to have a secret now and again. And for me, it's sort of like, I feel like you get to an age where it's like, hey, if you're really doing all the right things and the right thing, situation, dynamic, doctor shows up for you and you think that's something that makes sense, I think if it's really thoughtful, that does interest me, and I would never bullshit and sort of be like, I wouldn't. Right. I'm going down in a blaze of nature. It's like, I'm trying to be as natural as I can, but yeah, you know, I mean, I told him I need a different light. I said, what's going on? Do you like, is it sort of like a great luxury when someone comes in and they really haven't had anything?
Yeah, it is.
He's like, I'm the first.
Well, I mean, I don't shy away. I like the challenge of revisions.
I was going to say the technical parts.
Yep, and I like thrive on that challenge and love that. And, you know, I would say when I look at my results, some of my most satisfying are those ones, because I and my fellow surgeons know too, like what that took. But if I have somebody who's like baseline very beautiful and never done anything, that outcome is going to be just incredible. And so I can look at that before and after and be like, that was really beautiful, but actually this one took more skill set and input. And when I finish a procedure, I like kind of the next day or so take a pretty detailed like journal for myself on what I did, mostly because I want to remember it 3 to 6 months down the road when I get my actual feedback. I don't get feedback for a long time. So like you have a game, my athlete's mindset, you have a game and you watch film afterwards, you get the feedback the next day. I should have done this, I could have done that, this was good, and you get it immediately. You learn, in your short-term memory. Well, I have to file this away in a way that I can come back 3 to 6 months later when I have my videos and my photos, and I can go back to, okay, when I did Gabby's procedure 6 months ago, what were the nuances that I was thinking about? What decisions did I make? How did I make these little micro adjustments? So then I get this wonderful, beautiful pile of feedback that I can take like as film to be like, okay, this works great. I want to do more of this. I want to, you know, if I do this with the fat or this with the lift, or, you know, I get these like little things down the road. So it takes a while to get there though. It's a little bit of a unique thing. And it's, you know, the athlete's mindset is fun to talk about, but it's very different than being an actual athlete, right? Like when you're training for volleyball, you can pass 200 times a day. You get 200 reps of that, right? In one day, thousands a week, you know, tens of thousands.
By the way, it's not life and death.
Right. Well, yeah, but just like from that performance standpoint, you could like literally get the reps.
You're doing one a day.
Right. How do I get the reps? And that's where the visualization comes in. That's where the journaling and the later feedback comes in, is I can like kind of get reps. That's my version of getting reps, is I can go through it and be like, okay, here's the thought paradigms, here's the decision tree and things I can do that I want to do more of or do better. You know, I don't get to do it 100,000 times. If
someone gets the full deal, do you ever do anything with the lips? What happens with the lips?
Yeah, so the lips are part of that whole balance that we need to take into consideration. The upper lip, this is a great filler question too, right?
Well, the lower lip is what, 50% bigger typically?
It is, yeah. It's about 1 to 1.6.
Right, so, not in filler land though.
Well, not in filler land, and not when it's altered. And this is a great example, actually, going back to our filler discussion, of a place for filler, actually. Like some of our lip aging is related to volume loss. Stop it there. The problem is only a small part of our lip aging is related to volume loss, and then they just get pumped up over and over. And at that point, it sort of becomes like having breast implants done, right? You can do that. It's at that point, you're not rejuvenating anything. You're just changing what it was before. And that's fine if that's where you're at, but that's what lip filler really turns into, right? And for if someone's getting lip filler in their 20s, it's more in that mindset than it is in rejuvenating, right?
Different.
But when we get to 40s, 50s, 60s, 70s, now we're thinking of, well, how's the lip aging, right? We know that the filler you got in your 20s, 30s has migrated. I did a study with one of my fellows that we looked under the lip of like 50 consecutive patients who'd had filler in their lips, and it migrates all the way up through them. It's a muscle. It makes sense. If I put filler in my bicep, it's going to be all over my bicep in a few years from flexing it. Makes total sense. But the lip ages by descending because it's a free hanging piece of soft tissue like a breast, right? It's going to descend. It's going to change orientation. It's going to point down. So a lot of what looks like volume loss is really just in the lip inverting towards the teeth. It extends and gets longer. And for a lot of people, they lose their dental or their tooth show. If you look at your daughters and they talk, you're going to see their teeth.
Oh, yeah.
And if you look at somebody in their 50s and 60s, especially if they've had filler that weighs it down, they're going to have less tooth show. And so there's all these, this gets into that like temporal lobe stuff again of looking at the eyes and the mouth are the biggest for our nonverbal communication, which makes sense. So we're really in tune with what happens with our lips and our eyes, which makes them very high yield, bang for your buck, impactful areas to work if you understand how they are read. And the lip is big in that. So you can do a lip elevating procedure called the lip lift to change the orientation and position. It's much like doing a breast lift, right? When you're doing a breast lift, you're lifting things back up and putting them back. Maybe you're adding no volume back to it whatsoever, but things still look better afterwards. Maybe sometimes you do the breast lift or the lip lift and you add a little volume, which I will usually do with fat transfer at the time of the lip lift. So the lip needs to be considered. It's like wild. It shouldn't be the last thing we talk about. It's kind of last but not least. It needs to be included because it's part of that important nonverbal communication.
Big time.
Yeah.
Okay, final location, décolleté, the chest. Because that one, it takes a licking.
Yeah, it's a qualitative change down there big time. So some things that I'll use in that area. So when I say like I stop at the collarbones, I kind of wink. Like I usually am doing the chest as well. With a laser resurfacing.
Right, just like while you're sleeping, we'll give you some
Yep.
painful stuff that will make your chest, the quality of it improve.
Exactly, and that's almost always laser. I'm usually treating the back of the hands too, which is often very photo damaged in my patients. You know, just normal life. And so sometimes it's volume and laser with fat or something. Same with the chest, depends on, is it just qualitative changes from the sun? Is there volume loss there? Do we need to add some stem cell based fat to that area? Kind of goes along. Those become, I kind of tease my patients, those are like secondary or tertiary, third endpoints down the line.
Right.
I kind of call it the gravy. I have all the tools because I'm working on your face, right? But now I have the tools to make your chest better too. I might as well just use those tools over there real quick.
Yeah. I think your patients appreciate that.
Yeah, and in real life is where I usually am kind of telling somebody as I'm talking to them, it's kind of what I can see on you right now. It's whatever part of your upper chest you're showing and your hands. If it's, even with long sleeves, we still see those areas.
Are you always reading people's faces? Or are you able just to be?
Oh, yeah. This is a question that I get asked a lot. And I'm very much able just to be. And it's a much more peaceful, present place when I'm not working all the time. Not even that, but there are times where I'll see somebody and I can't miss it, and I'm like, I could change that person's life or whatever.
I could really help you out.
Yeah, but it is that mindset of help, right? It would be, like if you're a physio and you see somebody walking with a super crazy gait and
pronated
you're like,
foot.
Let's fix that, sometimes that happens, but for the most part, I'm very much able to be and be present.
Okay, final question. Is your mom alive?
Yeah, she is.
Have you done anything on your mom?
Ooh, I have.
Nice.
Yeah.
I like it. Imagine your son, you're like, sweetie, you owe me.
Yeah.
No, it's great.
Yeah. Yeah, my mom is in her 70s. She's thin. She's active. She's...
Hell yeah.
Yeah. Especially when you're going through training and stuff. They're like, oh, it's a little laser here, a little that, yeah.
You're like, sweetie. She's like, honey, you went too deep without that laser.
Yeah. The most forgiving person I could ever work on. She's stoked with whatever I do, right? Yeah, that looks so great. I'm like, all right, that's great. Yep. Yeah.
All right. Well, Dr. Chesnut, can you just remind people all the places that they can find you? And I just want to say also that, looking in these fields, sometimes you do feel like people have gotten out of control. And I do really appreciate the approach so much.
Thank you. Yeah.
Yeah. So it's great. But yeah, just share where all the people can find you.
Yeah, I'm most active on my Instagram. That's my name, Chesnut MD. And that's a lot of education and a lot of before and after photos, which is great. I mean, my practice is built off before and after photos. The education is just sort of get to know. And there you can, if you just want to go look, even at the 3 posts at the top, that'll kind of tell you a lot of what you need to know that are pinned up there. There's some presence on TikTok. If you're on TikTok, then my website's a great place to go look. That's clinic5c.com, just to go see a bunch of before and after photos in one place if you don't want to scroll through Instagram. But to be fully honest, like Instagram is where I put the most effort into putting content out that is applicable to just kind of getting to know me and these procedures, and then really looking at before and after photos and resonating with them, and, looking at what's great and what could be better. And that's what I do. That's what I want you guys to do too.
Well, thanks for your time.
Yeah.
Thanks, everyone. Thanks for listening.
Thanks for having me.
So thanks again for joining me and listening to the Gabby Reece Show. Make sure to like and subscribe so you never miss a conversation. And if anything showed up today that you find would be helpful to someone you know, pass it along, and make sure to share with us what really resonated and stood out for you in this conversation. Thanks again for joining us. Keep going, and I'll see you next time.